Good morning, everybody, and welcome to day 2 for Partnering for Change towards a new community model for mental health. My name is Larissa Taylor, and I'm the Deputy CEO of Policy, Advocacy and Communications at Mental Health Victoria. I'd like to start by acknowledging the traditional owners of the many lands across which we're gathered this morning. For me, it is the lands of the Wurundjeri people of the Kulin Nation, and pay respects to elders past, present and emerging. I would also like to acknowledge the lived experience of consumers, carers and family members across our program today and in the audience, and recognise the incredible expertise of the mental health professionals here today. Last Tuesday, we hosted day 1 of this event, which saw a vast range of expert presenters and panelists discuss what it means to provide effective community-based mental health care and the enablers and barriers to the design and delivery of the new community mental health model here in Victoria. Today proves to be just as engaging as we delve further into key aspects of delivering effective, safe and inclusive mental health care. The discussion today may be challenging for some people, and if you do need support, I encourage you to reach out to your support network or access one of the services featured on the screen in a moment. I would now like to introduce you to our MC for today, Sophie Scott. Sophie is the award-winning national medical reporter for the ABC, as well as a prominent public speaker and author. On behalf of Mental Health Victoria, I do hope you find today enjoyable and valuable. And Sophie, over to you.
Welcome everybody to this event. As Larissa mentioned, my name's Sophie Scott. I'm the medical reporter for ABC, and I'll be our MC for today's event. It's the second day of Partnering for Change. I want to acknowledge the traditional lands that I'm coming to you from, which is the Camaragal people of the Eora Nation, and pay my respects to their elders past, present and emerging. Today we can continue the discussion that we started last week, which was looking at the community models of mental health. And the Royal Commission, as we all know, has provided a really great vision for these community models of care, where people are going to be able to access services close to home with 2 systems, the one for infants, kids and young people, and then adults and older adults. And the timing of this symposium is great because the consultation for these services has begun, as many of you know, and will close later this month. And the first 6 of the services will be built by the end of 2022. And we're going to hear an update on the reforms, which is going to be really exciting. Some of the key topics we're going to be considering today, including how these new models might look at responding to people in crisis, some practical tips on how to operationalize intersectionality, and how to strengthen cultural safety and inclusivity across the models. We're going to hear from experts, including Craig Wallace, the new CEO of VMIAC, Katherine Whetton, as I mentioned, the Deputy Secretary for Mental Health in the Department of Health and Human Services, Dr. Adele Murdolo from the Multicultural Centre for Women's Health, Simon Pont from Suicide Prevention Australia, as well as lots of other great speakers. Now, this is your symposium. It's as much for you in the audience as it is for the people who you'll hear from. So we want you to get as involved as possible. And there's a number of ways to do this. If you're on Twitter, you can follow Mental Health Victoria, which is their Twitter handle is @MHVic. And you can see on the slide, you can see there in front of you. If you're on Instagram, I'm on Twitter, but also on Instagram, I'll be posting some updates on Instagram today. My handle on Instagram is Sophie Scott and the number 2, and the hashtag for today is Partnering for Change. There's another key way that you can get involved, and this is if you're at the event last week, we're using this the same technology. The website you go to is menti.com. It's www.menti.com, and there'll be a code that will come up that you'll see that you can put in, and that way you can be part of the word clouds, you can vote on questions, you can take an active part in most of our discussions, particularly the panel discussions. So when we get to that point, you'll be able to be really involved and just go to menti.com. It's free. You just pop the code in and it's all good. So I just have to mention a few housekeeping details. The symposium is being recorded and all the presenter slides will be sent to all of you in the coming week. And hopefully by the end of today, you'll be able to know more about collaborating effectively in the delivery of these services, know more about how to draw on the existing models of care, be aware of what we need to do to make these models a success. And the Mental Health Victoria will also send you a short summary in a few days of the event. But in the meantime, let's get tweeting, get on Instagram. We would love you to tweet out and put on Instagram some photos or your favourite quotes or moments from today. If you can tag Mental Health Victoria and my name as well in any tweets or Instagram posts, then we can resend them. So now it's my great pleasure to welcome our first speaker. I'll just make sure that he's ready to roll. Our first speaker is someone who's probably known to many of you. Craig Wallace is the new CEO of VMIAC, the Victorian Mental Illness Awareness Council. And before this role, he was with Mental Health Victoria, Mental Health Reform Victoria, where he worked as a senior advisor in lived experience. And he worked on the early implementation phases of the Royal Commission. And we're delighted to hear from him today in this important presentation. So I'll just make sure Craig is ready to roll, but we're really looking forward to hearing what he has to say as his new position as the CEO of VMIAC. So let's just see if Craig is ready to go.
Thank you,
as
Sophie.
I mentioned, yes, there's Craig, there he is. Fantastic. Fantastic, Craig. Look, I will now depart and I'll leave it. I'll just hand over to you, Craig. Looking forward to all your insights. Thank you very much for your time today.
Thank you, Sophie. Thanks for that introduction, and thanks, Larissa, for kicking us off this morning. I'm just going to share my screen with a few slides that I'm going to talk to today. Bear with me while I do that. All right. Privileged to be here today, and a privilege to be leading our very strong consumer mental health peak, VMIAC, in this era of reform. My name's Craig Wallace. I use he, him pronouns. And thank Larissa for acknowledging country this morning. And I would just like to also add to that, just to say that wherever we are in this nation, politically and socially constructed as Australia, we're on Aboriginal land that's never been ceded. I'm joining today from Jar Jar Wrong country in Bendigo. So pay my respects to elders past and present. Extend those respects to any Aboriginal or Torres Strait Islander people joining us in the conversation today. And note that VMIAC is a statewide organisation, and we work across many Aboriginal lands, all which have not been ceded. Thank you. Okay, I'd like to just make a recognition here that in the conversation today, we have people who have consumer lived experience. And so when I say we, I'll be talking about consumers as the group we, but at some point in my presentation, I'm going to shift to be talking about we, about all of us. I'll just see if I can time that where I want it to. And I just would like to extend my hellos to families, friends and supporters of people who experience mental ill health who would be in the conversation here with us today. I'm going to talk a little bit my own personal experience in a certain way today. All of us at VMIAC have a lived experience of mental ill health and recovery, or psychological emotional distress. We use our own words to describe our experience, but we all have that type of experience. So just a content warning for people: look after yourself. Some of the material that I'm going to talk about, not much of it, but a little bit about my personal experience could resonate strongly for you. So take your time, walk away from the screen if it's not working for you, yeah, make sure you have someone to talk with if something resonates very strongly for you. Okay. What I wanted to start with talking about today, as we're thinking about new ways of doing things out of the amazing Royal Commission, which heard from so many consumers and carers, or family, friends and supporters who put forward their stories, and indeed clinicians, executives, emergency services, and all of those people who put forward their ideas in the Royal Commission. I wanted to talk about the VMIAC Declaration. It's on our website, and the links there, and these slides will be available to you as well. So in the declaration is the result of some research that we did at VMIAC about what it is that consumers want. In the people that support them, the services that are provided to them, and what might actually be happening in those spaces. So the first question here is we asked what kinds of people we want to support us. So when we're thinking about new ways of doing things, we need to listen to consumers, because consumers are the end users of these services that we're designing, and consumers are saying, these are the people that we want, or indeed the actions that we want to be happening in the services that we access. So if you're not familiar with the word cloud, the largest words are the words that are mentioned the most, and vice versa with the smallest words. So you can see there's really strong support for peer workers and lived experience workers, people who purposefully and intentionally use their own experience to support others, or indeed to try and change the system in sort of structural or systemic ways. Okay, so that's the first one. I've got 3 slides, I think, from the declaration. And I should say too, I'm going to finish in time, so there's time for some questions as well. So we asked people what type of places and spaces and services they would like in the future. So when we're thinking about all of us working together to make these new local community mental health settings and spaces, here's some of the things that the consumers are asking for there. Gardens, learning spaces, peer-run choices. Consumers like to have choice in what they can do, and they like to have some control of the environment and the interactions that they have with people, and that's a pretty standard requirement for a service to be trauma informed as well. Okay, so that's move to the next one. Okay, and this is about the kinds of actions that people like. So it's interesting because I think when we all line up for this conversation, we come with our discipline lens. Is it a consumer lived experience lens? Is it a carer lived experience lens? Is it a social work, allied health, psychiatry lens? It's interesting if you ask consumers, they're not so fussed about who it is that provides these things, but these are the things that they're interested in having. So you can see groups is a big one there, and therapy as well. So there's a real desire from consumers that's been borne out in the Royal Commission final report that they want, or we want, something that is beyond just a medical model, and has other ways of helping people out, which are empathic, compassionate, and indeed build on people's strengths. Okay, well, I've gone backwards there. Okay, so here we are, and we're thinking about working together, making a better system in the period of huge reform, and some of it's hard, some of it's really hard work, and it's hard to get it right, and it's hard to do it with the right process. And I've got a few tips coming up as to what might make that a little bit easier. Probably comes no surprise to you that I'm going to talk about co-design. I'm going to try and add a little bit of angle to the co-design conversation. I appreciate quite a number of you have probably been in lots of conversations about co-design, and I know some people have said to me, why do we have to do co-design? It takes too long, it's messy, like we could just get this done quicker. I think if we get things done right from the start, involving all the people that we need to from the start, we are going to get a better outcome, or we might just have to do it again if we don't. So when you think about co-design, I want you to, if you haven't already thought about it in this way, we mostly work in multidisciplinary teams in the system. Now when I'm saying we, I've moved from beyond consumers to say we, to all of us. We mostly work in multidisciplinary teams, and there might be lived experience in those teams, and there might be other disciplines in those teams as well. When we think about what we need for co-design, it's a very, very particular set of things that we need to happen. How come we're not thinking about those things when we're thinking, and perhaps you are, when we're thinking about multidisciplinary teams? I did some work once with a recreation provider, and they consulted around how do we make our gyms and recreation centres better for people who experience mental ill health. And it was interesting because one manager suggested that this was all too much and that they were really, really busy and they couldn't do this. And another manager said, I think this is going to be amazing because if we do these things, this is going to be a better gym and recreation centre for everyone. And we're going to do much better as a business. So I think it's worth thinking about taking the time and doing things right. And what I've got in the orange little rectangle there with curved edges, by the way, is just because we're working on something together, it doesn't actually mean we're doing it well. And I think this is really going back to the we, as in being consumers. What we think is this is fantastic. We're now being asked to be at the table in discussions, and sometimes now we're being asked for 2 or 3 of us to be at the table, and even we're being asked to be involved in redesigning the table. Even better. Let's go right to the start. But just because we're there doesn't mean it's working well, and there's things that we need to do to make sure that consumers' involvement is meaningful and worthwhile. Okay, so have a think about co-design as I go through the next slides, and have a think about your work and working with other people who might have a different background to you, a different frame or perspective, and also might have different access to power as well. Okay. I'm going to circle back to these at the end. There's going to be, it's an anecdote or anecdotes about power differential, table tennis balls, lithium, and a prototype acute inpatient bedroom. I'm going to keep you in a little bit of suspense about that. All right, so a couple of local sources worthwhile looking at. I think sometimes in our busy work, we know these things exist, but we don't have time to look at them. So the lived experience engagement framework. So that's on the department's website, and it's thinking about when we involve people, are we informing them? Are we consulting them? Are we involving them? Are we collaborating? Or are we empowering them? And that's sort of being a hierarchy of involvement. Key message. Be clear about what it is that you're doing. If all you're doing is informing, make sure that people know that. Okay, so if you're involved in a change process and all that happens is you're informed, there's quite a number of levels above that perhaps you could be involved with. Okay, and then we talk about principles or values, or what is it that we're doing, and in the LEAF, the lived experience engagement framework there, people are being purposeful, prepared, genuine, and inclusive, and they're making sure that they communicate. It's really important when we're working together that we communicate, that everybody knows what's going on and everyone knows at the same time. It's not that people have some sort of power by their access to information. The other source I wanted to draw your attention to is the co-production guide, Putting Principles into Practice by Kath Roper, Flick Gray and Emma Cadogan. So that was a co-produced document, amazing, about co-production. I guess lucky that the method matched the topic. So that's got a whole bunch of principles. I'm going to go to a few of the questions now. I'm going to have to skip through this in the interest of time. So but have a look at these questions on your screen. I'm not going to talk to all of them. And this is questions for discussion when we're bringing co-production partners together. And as I asked you earlier, think about your work, your multidisciplinary work. And so are these questions useful there as well? Because I reckon they are. Okay. How will we make decisions? How will we communicate with each other? Okay, slide 2 of these. Okay, how will we know if we're working to the principles we agreed on? What if people experience difficulties? What happens when people disengage? Not just in co-production, but in multidisciplinary work. People disengage, they're not putting forward their ideas. They're not as committed to the outcome. You got to be careful of that. Okay. I want to draw your attention there to question 18. what's important to you? What's good support for you? Because I'm going to relate this to the anecdotes. So this is about me now. This is about my personal lived experience. What's important to me? What's important to me? I have a 30-year history of accessing or trying to access Victoria's mental health system. And what's important to me is that people think I'm useful, because I've spent a heap of time in a mental health system which has positioned me as not useful. And beyond that, it's positioned me as a burden and something that needs to be fixed. So what's really important to me is that I'm useful. And I think if you ask a whole bunch of consumers about that, a lot of them would say, they would not use that word, but it would be getting to the same point. And if you're involved in a multidisciplinary collaboration, I wonder if it's you want to feel useful as well. All right, so here we go. Somebody worked out a story that's got all of these things in it at once. What I'm going to talk to here is one, power differential. We meet for co-design. I've been in a co-design setting where the consumers said we need to talk about power. And the most important person in the room in terms of self-importance and also access to traditional power, so the most powerful person in the room, I should say, not important, said we don't need to have a conversation about power, we're all equal here. Okay, so I hope you've worked out what's wrong with that. We can't have the most powerful person in the room define and control the conversation about power. So that doesn't work. All right, so what then happened? So happy, good news story. We did stop and exploded out that conversation about power, and then everyone felt better. So I'm wondering about this work that we're doing for local community mental health settings, new places. Let's talk about power when we are doing this. Let's make it explicit, the conversation about power. And do something about it as well. I think we're really good at getting to the point to talking about things, but it's then actually making them into actions. So stop your item on your agenda 5 minutes early and say, what are the actual actions here? What are we actually going to do now that we've had this amazing conversation about this? Okay, so don't do the table tennis balls story. And the table tennis balls is when the consumers on an inpatient unit, they have their community meeting. It's Monday morning, 9:30 after breakfast, and there's a table tennis table and there's no balls, and the table tennis can't be used. And the consumer says in the meeting, can we get table tennis balls? And then it's whoever it is facilitating that conversation. And they write it down in the book, and they say, oh, we'll just write that down in the book. And then they go back to the nurse's station, and the book goes up on the highest shelf in the back corner and doesn't get looked again for a week. So that's an example when people have spoken, they've taken a risk, they've been vulnerable and said, this is what I need. In this case, it's table tennis balls. And then the conversation's there, but the action's not there as well. So again, let's make sure the actions are clear so that we're doing this, because we're coming together to talk quite often and think, but it's been clear about what the actions are, and making sure that everybody, including the people with the least traditional power, know what those actions are. Okay, now lithium, this is a very personal one for me, not trying to give too much away here about my background, but so I went into the camp, and I want to think about having a co-design mindset here. Okay, so I went into the chemist and got my lithium, and the pharmacist came back with lithium and said, have you taken this before? And I was like, duh, it's a repeat prescription. But actually, I didn't say that. The point is, what I did say is I've been taking this for 30 years. Which was not to be smart, but was just to have a statement of fact. And the pharmacist didn't know what to say. If we're in a co-design mindset, and remember, I've put my little ticket in saying what I need is to feel useful. What I'm looking for is the pharmacist to say, hey, that's amazing. That's a lot of experience. What about writing a brochure about your experience of using lithium? My kidneys are fine, by the way. Let's make that experience useful and bring it into the dialogue, and not just leave it hanging and leave me feel vulnerable about that experience. And again, I think we can apply this to all of our conversations. The other one is a prototype acute inpatient bedroom. I had the privilege of having a look at that, a part of the beds expansion program that came out of the interim report and the Royal Commission. And I said to someone who was involved in that work, I said, I spent 172 nights in one of these rooms, which over 30 years, if you're doing your maths, is about half a year in 30 years, which is about 1.6% of my life since age of 17 that I've spent in one of these rooms. And they didn't know what to say. And what I'm saying here, let's take our co-design mindset, and I've put in my thing saying I want to be useful. Let's say, hey, you must have a lot of ideas about what could happen in these rooms and how they could be designed, because you spent 172 nights in them. That's amazing. All right. Okay, we're really close to time here, so we'll move on to acknowledgements. So nobody does anything on their own. Everyone gets help, and I work with a great team at VMAC called Team VMAC, and so acknowledgement to them that the things that they've been doing in the last weeks, it's given me a chance to have a think about what I want to talk about here. Robin Litfin-Salter does our comms. She tidied up my slides for me and made them work. Amazing. And of course, you don't get very far in life when you have major mental health challenges in your life, unless you have family, friends and supporters. Well, it's not always the case, actually, but for me, it has been the case. I have very amazing family, friends and supporters all of the time. All right, so I'm over to you. I think Sophie's going to moderate some questions, maybe.
Yes, I'm going to ask you a couple of questions. Thank you, Craig. Thank you for that presentation and for sharing your experience as well. And I'll just ask you one or two quick questions, but the audience, if you would like to ask questions as well, you can see, you just go to menti.com and put in that code you can see on the screen. It's 42703529. So that'll stay up for a little while. Just so anyone in the audience, go to menti.com, pop in that code. And while we're doing that, Craig, I just wanted to ask you one or two quick questions. You were saying, and I really resonate what you were saying about the importance of action. You know, I think people are very good at talking, but what really makes a difference is action. What actions do you want to see from a consumer point of view? What actions do you want to see with the development of these new community models? What's key for you in terms of the actions that need to happen to make sure that these models are appropriate and really what consumers need?
Yeah, thanks, Sophie. So I think that's the local model. So you need to ask local consumers in the first thing. Before you do that, I think you need to have a meaningful engagement with the local Indigenous community as well. As consumers, we are sort of quite highly caring, feeling people, and that's really important to us. So engagement with the local Indigenous community, and then asking people locally, consumers, what they want in their service, and the service having you know, proper local connections so that people can be referred appropriately. So it's embedded in the community. And what consumers want is to be known more than as a diagnosis or a walking set of symptoms or a walking problem, as I referred to in my presentation. So they're looking for services which are going to take the time to know them, to like actually know them. And as anyone will tell you, the better that you know someone, that you can provide a better service as well. And for those of you who look at things from a risk framework, the better that you know people, probably the less risk there is in whatever it is that you're providing.
So we've got thank you for that. We've got a few questions coming in. So I might just try to get through them as many as we can, so the answers can be nice and short. Oh, there's so many. Thank you, Craig, for your open and inclusive talk. How can all people, consumers, families and supporters be brought to and included just beyond consultation? So how do we make sure that we're including people not just in the consultation phase, but sort of in an ongoing way? I think that question is. Yeah.
So I think it's a great question, and I think it encapsulates like where we're up to. You know, we do have a difficult task in terms of implementing you know, 9 interim recommendations and 65 final recommendations, and some of those are on timelines which are pretty tight. But what we need to do is think about, are those timelines appropriate, and is it in fact, do we have the time and the resources to go beyond consultation, as the question asks, and involve people in more meaningful ways, and this can take time, as I said, and it can also take resources, and it's also a mindset as well, about keeping informed. You know, if people are consulted, then communicating with them beyond just the consultation and involving them in further activities. Sometimes, you know, it's not always possible to do pure 100% co-production and co-design. We know that, but what can we do to at least have elements of that present in the work that we do?
So a question that has got a lot of votes is, do you think therapists should share their lived experience to normalise and reduce stigma and reduce the power dynamic? So I guess that's in a therapist consumer interaction.
So I think what we have here is a couple of aspects to that question, and one is that therapists may or may not be part of a profession. So people can call themselves a therapist if they like, but people can be part of a profession, like, for example, psychology, where they're a therapist, and so there may be particular codes of conduct and things within certain professions which provide guidance and indeed barriers here. I think there's a real gap, say, in psychology, between where is it that the lived experience of psychologists fits in with the provision of services, and that's what I think this question gets to. I mean, we can have, you know, people who are taking a sort of a Freudian approach, or who, as a therapist, won't even mention a thing about themselves because they want to be a blank slate for the person to basically project onto. And then we can have the other end of the continuum, which is, you know, someone new as a consumer worker who talks about their lived experience, personal lived experience all of the time, without being purposeful and intentional in it. So, I mean, I think it's a very individual decision for people to make, but if people are going to make that decision, they need to think through, what are the implications for this? What support do I have for myself if I'm going to start talking about this? And how do I ensure that my client, if we're using the word client, doesn't feel responsible for looking after me, and all things like that. So, I mean, I'm actually, as a general overall, I would say yes, I support that, but it needs to be done intentionally, purposefully, and with the right support, and thinking about not only the short term but the medium term and long term consequences of that.
Okay, thank you. Another question is, how can we differentiate between meaningful engagement and co-design and tokenistic consultation in inverted commas?
I'll ask the people involved, I think. Yeah, what we should be having exit surveys on when people are involved in co-design activities. And ideally, we should have a lived experience evaluator who's evaluating the co-design and can be asking the people involved, what was that like? What did that feel like? Do you see your ideas represented in this final product? And what was that process like for you? Did you feel energized by that process, or did you feel really shut down and not listened to?
Another question is, we all know the negatives about, well, this person saying we know the negatives about the public mental health system. Are there any positives that we can build on through the reform process?
Yeah, absolutely. I mean, I think
what's working well and amplify the parts that are working well.
Yeah, so people often talk about having a strength-based approach, so we can have a strength-based approach to the system. There are really good pockets of work, and there's amazing clinicians who work in the system, but we have had, you know, a government even before a Royal Commission telling us the most powerful person to change the system, you know, Martin Foley, when he was the Minister for Mental Health, telling us that the system was broken. And so that's hard for everyone involved to hear. And, you know, there's other ways of saying that. You can say the system is not delivering the outcomes that consumers want. It's not being the system that families, friends and supporters are hoping for. And it's not providing a space for all of the staff who work, to do the work that they want to do. Because they're not able to work in the ways that they're trained or the ways that they would like to, or even, the intention they had when they chose that career it's not really working out in that system. But again, I'm talking about the negatives. So the positives are, there's some great programs out there. Ask consumers, get consumer evaluations, get consumer reported outcome measures, and then we can talk about those as exemplars for what we're looking for.
Yeah, and what you mentioned there, like in New South Wales, where I'm based, they do have a system in the public health system where they capture patient reported outcome measures, and so that's collated and the data exists on what patients actually think worked well, which is really good.
Yeah, well, if you're not
we've
asking,
only got 1 minute left to go, and I think this is an important question. How can we encourage people to be open about their mental health experience at their workplace? We'll just finish off with this question.
Yeah, so this is one that's really emerging now, and also I think it's a fantastic question. Sometimes in employee climate surveys, they ask the question, can you bring your whole self to work? And get people to rate that from 1 to 5, whereas 1's not at all and 5's yes, absolutely. We probably need to add to that a caveat of, can you bring your whole self to work, if that's indeed what you want to do. But so that could be people's mental health experience. I've seen jobs advertised where they say it's in the mental health system, it's highly desirable that people have a lived experience of mental ill health and recovery. So that's fantastic. But what happens with that information? People put in their CV and they put, I have this experience in their CV. They're really brave and they do that. And then they go to interview and they talk about it in an interview. But then that information doesn't actually get passed on to their line manager. And then it's sort of lost in the ether a bit. So it's a responsibility of the workplace to make sure that people can have those conversations if they want to, but have them in a way that's linked to supports as well, so that people just don't feel vulnerable, that they've sort of talked about their lived experience, which is a brave thing to do, but then that there's not something there for them to support them. And I think the best thing to do is to ask those people, what sort of support do you need, given that you've talked about this? Is it you want to start a bit later and end a bit later, or is it you need meetings?
In a practical sense, make sure that those supports are there as well as, Oh, look, that's excellent, Craig. We've got lots more questions, but we need to move on. But we really appreciate you giving your time this morning for this presentation and your own story as well, which is always so powerful for people to hear. And congratulations and thank you again for your time. And we look forward to keeping in touch with you. And it's been amazing having you kicking off today's symposium. So thank you very much, Craig.
Sophie, have a good day, everyone.
Thank you. So that was a really interesting kicking off for our symposium today. We're now really lucky to have someone who's been so key to implementing the reforms of the Royal Commission. As you may have heard, Katherine Whetton spoke to us in a previous event, which was fantastic. So I'll just introduce her. Katherine Whetton is the Deputy Secretary for Mental Health in the Department of Health and Human Services, and she's going to be providing an update on the department's progress in implementing the reforms. So Katherine, welcome. I will hand over to you now if you want to unmute, and it's in your hands now. Thanks so much for your time. We really appreciate it.
Thanks so much, Sophie, and good morning to everyone, and thanks for the warm welcome. I'd like to acknowledge we are all meeting on Aboriginal land, and I acknowledge them as the traditional owners. I'm on the land of the Wurundjeri people of the Kulin Nation. I pay my respects to elders past, present and emerging, and any First Nations people who are joining this symposium today. I'd like to recognise all people with a lived experience of trauma, neurodiversity, mental ill health and substance use or addiction, and their families, carers and supporters. And this recognition extends to the clinical and non-clinical workforces who work to support those with lived experience. Also did want to acknowledge Craig Wallace's great presentation just then. It's so great to have a passionate and thoughtful CEO at VMIAC, and I think Craig's made some really great points this morning in his talk. So, but thank you for inviting me to present today, and really delighted to have an opportunity to talk with you again. I think it's also great that the Minister for Mental Health was able to join for the opening address on the first day of this symposium last week, and it's always great to hear from the Minister and his hopes for mental health reform. He's also very passionate about delivering on the Royal Commission recommendations. So I hope many of you were able to make it for that presentation. Thank you too to the many individuals and across many organisations for taking the time to attend today, and thank you also for all of your ongoing commitment and efforts in the system. Many of you and your colleagues will have found it challenging for many years to find your way through a system that hasn't always supported you and your consumers. And now you may also feel that things are still challenging with change and some uncertainty of what lies ahead and when it will happen. There is and there will be a lot of change arising from the system transformation recommended by the Royal Commission. The Royal Commission's report was only released 6 months ago now, but it did mark a very important turning point for the mental health system and for the mental health and wellbeing of Victorians. Change of the scale that's been recommended by the Royal Commission is certainly not easy. It will take a lot of time, a lot of work, and there will inevitably be some disruption. And we know too that the pandemic is compounding some of what we were already finding challenging, and no one is untouched through this pandemic. And we know that mental health services and the workforce are under enormous pressure at the moment. And we know that families, adults, children and young people are finding the extended lockdowns very challenging as well. So I do think at a time like this that kindness and empathy really need to be front and centre of our work together and all of our interactions as well. I think everyone's finding things pretty challenging at the moment, both professionally and personally. So I think it is just worth us reminding ourselves of that as we do our work. But it is my hope that we can keep making our way forward on this mental health and wellbeing reform agenda together. And as challenging as things are at the moment, I'm really excited and continue to be energised by the fantastic work and improved outcomes that we can achieve by working together. And again, listening to Craig talk this morning is just one of those things that just keeps energising me as we take forward this work. My division, the Mental Health and Wellbeing Division in the Department of Health, is genuinely very committed to collaborating and working together in a way that's genuine and productive. And we have such an important journey ahead of all of us. And I'm keen that we hold on to the momentum created by the Royal Commission and further reinforced by government's commitment. But also, and Craig touched on this, that we do progress the work in a way that is sustainable, thoughtful and coordinated. A shout out to Mental Health Victoria this morning. These symposiums really are a great way for people to learn from each other and discuss the road ahead, and really applaud your efforts on that. And again, for those joining today. And it's great to see that the theme of this symposium, Partnering for Change Towards a Community Model for Mental Health, the Royal Commission outlined a vision for a future mental health and wellbeing system that's strongly oriented towards community-based treatment, care and support. And that it'll be a system that offers people the full range of supports in their own communities and close to their families and carers, so they can recover and lead contributing lives. It is well recognised that community-based services are unable to keep up with current demand, and the Royal Commission emphasised that major investment would be needed to deliver this community model that they talk about. We're really committed to this vision and recognise that the community-based system does need building. And so, as we've all seen, in May this year, the state budget did commit a record investment of $3.8 billion over the next 4 years for mental health. And that included more than $1.5 billion for community-based care. And this investment is bolstering our work to deliver the new system, but it's certainly not the only investment that will be made as well. And I've talked about this before at the last symposium, just that our journey, it's a long one. It's a 10-year journey, and that we are in those very early stages. So I'm keen today to talk more about the work that's already underway, and because of today's theme, I'll spend a bit of time talking about how we're shaping up the community-based system, but also given everything is connected, I'm keen to spend a little bit of time also talking about where we're up to on some other key reforms and what's coming next. So the Royal Commission pointed to the need for greater partnerships to reduce system fragmentation and improve consumer outcomes. And I know this is also a big feature of today's program, which is really fantastic. And partnerships can take many forms. So there can be partnerships between service providers, partnerships within and between governments, and also partnerships between government and the sector. Also keen to touch on how we're building up our own capacity in the department and also how we're engaging with you. And because we're building from a pretty small base and facing a big undertaking, I do ask, keep bearing with us as we move forward, and I'm really looking forward that we keep doing that together. Before I do move into the presentation though, I did want to go back to COVID very briefly. We're very aware of the mental health and wellbeing challenges being faced by Victorians due to the pandemic and continued restrictions, and we're hearing, as we all are, hearing a lot about that every day, and also the continued and increased demand for mental health and wellbeing services, and then also what that means for our workforce. So I wanted to just make sure to let you know the department is very actively looking at some additional immediate initiatives that we think will help, and more to come on this very shortly. Next slide. Thank you. So just going into where we're up to on some things, and just reminding ourselves about the Royal Commission focus on the community-based services. So the new mental health and wellbeing system will be centred around community-based services. The expanded system will offer a full range of supports that people need, which includes growing the community-based service offering and organising services at a local, area and statewide level. And so some of the flagship reforms underpinning this are at a local level, establishing 50 to 60 local adult and older adult mental health and wellbeing services. And the first 6 services will be operational from the middle of next year and by the end of next year. And I'll come back to this a bit later. At an area level, establishing 2 aligned systems, one for infants, children and young people, and one for adults and older adults, with strict age eligibility criteria removed. And also establishing new governance, initially through 8 regional interim regional bodies, and then over time, regional mental health and wellbeing boards that will support a new approach to commissioning of services. And really the successful delivery of this new system relies on really setting up for those strong foundations, and I'll touch on some of those reforms a bit later on. Next slide. Thank you. As the Royal Commission set out, the new system will be comprised of the 6 levels that we saw on the previous slide, and the Royal Commission recommended 50 to 60 new local services for adults and older adults, and then in addition to dedicated local services for infants, children and family, and services for young people. Area level services will provide tertiary high intensity services for people with acute or complex needs. There will be 22 area services for adults and older adults and 13 for infants, children and young people. And for infants, children and young people, area-based services will be streamed into those aged 0 to 11 years, and then those aged 12 to 25 years. And at the most specialised level of care, the Royal Commission recommended an expansion of Victoria's statewide services, delivered in a way that minimises the need for people to travel far to be able to access those services. Next slide. Thank you. So there will be 2 age-based systems at an area level, and this is so that treatment, care and support is developmentally appropriate and there's equity of access regardless of age. And this is a real strength, I think, of the Royal Commission's report. And each will operate with extended hours and respond to crisis calls from anyone in the community 24 hours a day and 7 days a week. Area level services will be expand pretty significantly so they can see more people and provide more treatment. And this expanded capacity will be based on the core functions of the system that the Royal Commission set out and that you can see on the slide there. And this is really so that people can access consistent contemporary services irrespective of where they choose to receive care. Importantly, local and area-based services will be formally networked to be able to promote a staged care, and this will occur through several mechanisms. A new access policy will be developed for area services, and as recommended by the Royal Commission, people receive most of their care from a local service close to their home and community, and they'll need a referral from a local service to access an area service, unless they do present in crisis or have been referred by a medical practitioner from another system. There'll be formalised shared care between area and local services. Area level services will be funded to provide primary and secondary consultation into local services so that every measure is taken to maintain care continuity in the person's community. Over time, there will be a gradual shift to more regional planning and commissioning through the 8 regional mental health and wellbeing boards that I mentioned before, and I'll go back to as we go through this. And there'll also be encouragement and support for co-location and shared workforces across the community teams in area and local based services. So the new system will offer the full range of supports that people living with mental illness or psychological distress need. And to do so, area-based services will deliver integrated clinical and wellbeing services through a partnership between a health service and non-government organisation. To deliver on this, each health service will need to formalise a partnership with a wellbeing provider by the end of this financial year, end of 21-22, and we'll have more that we can share on this over the coming months. This is all pretty extensive change compared to the current system, which we're very conscious of, and this will need to be implemented over several years. Next slide. Thank you. So the Royal Commission recommended establishment of 8 interim regional bodies as a precursor to the future establishment of legislated regional mental health and wellbeing boards. And the diagram there that comes from the Royal Commission report shows the interim bodies will be established. You can see closely, it says by mid-2021. So we are still working on that. But they're to be established this year, and they're the first step in decentralised governance. And as mapped out on the slide, they form part of it's a 5-year plan to transition functions from the central department to the regional boards by the end of 2026. This is absolutely one of the areas where we've got quite a big journey and lots of work to do to see that vision for the future boards and how we're going to get there. But just on the interim bodies, so each of the interim regional bodies will include a chair and 5 members, which includes a person with lived experience as a consumer and a person with lived experience as a family member, carer or supporter. And the department will be commencing very shortly and hopefully this week, a merit-based and public expression of interest process via the Boards Victoria website to appoint chairs to the interim regional bodies. So we're looking for great chairs across 8 regions across Victoria who have and who can have strong local knowledge and build strong local relationships, who have good governance experience and who understand and are passionate about mental health, which could also include having lived experience of mental illness or psychological distress or a carer of someone with mental illness. The recruitment of the chairs is a first step in the establishment process, and once appointed, the chairs will work with the department to recruit and appoint remaining members to each body. The chairs will also support the division as we engage with stakeholders to determine the final alignment of the 8 regions. The chairs also and the other members will play an important role assisting the department in that, and that's step 1 column, with needs assessment and planning for services and reforms. Next slide. So the recent budget committed to establish the first 20 of the new local adult and older adult mental health and wellbeing services. And this new level of service will create a broad front door to the mental health system. Local services will support Victorians aged 26 years and over to receive timely, high-quality mental health treatment, care and support. So core functions will include initial support discussion and a comprehensive assessment, clinical treatment and structured psychological therapies, wellbeing supports, education, peer support and self-help, and care planning and care coordination. So as we know, the government has already committed services in the first 6 priority locations, and that they would open from mid-2022 and then by the end of 2022. And just a recap, the first 6 are Benalla, Brimbank, Frankston, Greater Geelong, Latrobe Valley and Whittlesea. So we're engaging with our sector and local communities as this work progresses. And 2 weeks ago, the department held a forum with the non-government sector to consult on the latest developments on this work, including opportunities to be involved in local services reform. I know there's a lot of interest about it. And so more than 70 people came together virtually to talk about recent actions in the reform, as well as some other related reforms. And you can see the outcomes there on the slide. We had a really helpful open question and answer session as part of that, and we had some really great questions raised, such as the alignment of the regional bodies with Commonwealth-funded primary health networks and the capabilities of regional body members, including those with lived experience. We also talked about the intersections between mental health reforms and the National Disability Insurance Scheme and the National Mental Health and Suicide Prevention Plan. We also talked about cultural safety across service delivery and careful statewide planning so that we can be sure to have workforce consistency across the region. So it's really, really clear from that session and other conversations we're having too about the sector being very willing and very able to contribute to this work, and we really do appreciate it. Next slide. So local services reform is well underway. You can see here progress and next steps. The services will come online at different times and through different arrangements depending on the population. And for example, if we look at, so this is for the adult services, but for children and infants and children aged 0 to 11 years, we're establishing the first 3 infant, child and family health and wellbeing hubs. For young people aged 12 to 25 years, support's being provided through the existing Headspace network funded by the Commonwealth. And then for adults over 25, we're establishing these first adult and older adult local services. The work to establish them is progressing at a pretty fast pace, and it is at a faster pace than some of the other reforms because of the timelines that government had asked for us to deliver these. And as you can see, the first 6 sites will be opened by the middle of next year and then by the end of the year. So there's some really important work that we need to do to support these services to open. And so alongside development of a service framework, a commissioning strategy is also being developed, and we're going to be holding market briefings when we can give a bit more detail about that process. And there's also service planning underway about future site selection too and prioritisation. Now, a market process for a call for submissions for the first 6 sites will commence in October. Our engagement process at the start of this is particularly concentrated as we work to shape up those first 6 sites, but I really want to assure you that people with lived experience as consumers and carers, local communities in their respective areas will also be engaged as we do keep developing and rolling out these local services across regional and metropolitan Victoria. Building these 6 new services, the first ones by the end of 2022, is an undeniably ambitious task, and we can't do it without your support. So I do look forward to continuing to work closely with you as we can really drive and build momentum for this reform. Next slide. Thank you. So onto the mental health workforce strategy. So this is something the Royal Commission has recommended be delivered by late 2021, and it will provide direction, guidance and advice around Victoria's mental health workforce needs at a systemic and statewide level. Early focus so far has been on engagement. We've formed a mental health workforce technical advisory group, and we held a mental health workforce forum in late July. We had more than 140 people attend that. And so you can see the outcomes on the slide there, but the forum really did surface some of the critical challenges and some very important opportunities for us to pursue. So for example, participants spoke about the critical workforce shortages in the current system, and also identified opportunities for further work, including expanding recruitment pathways, investing in workplace culture, and expanding the scope of practice to improve job satisfaction. Participants also identified trauma-informed care as a necessary capability in the workforce, and seeking to support building to build capabilities to meet the needs of consumers and carers, and innovation that means that the right disciplines are included in models of care. We talked a lot too about rural and regional workforces and in some detail, and participants highlighted the need for a comprehensive incentive scheme that considers working conditions, financial incentives, cultural and social supports, and then coordinated undergrad training and placement programs as well. And then finally, participants identified opportunities to improve workforce wellbeing by building links between metropolitan and regional workforces, and also improving supervision and professional supports. Next slide. Thank you. So the next stage of work has been targeted engagement. So approximately 150 representatives across 76 organisations have come together to form what we're calling these 4 specialised targeted engagement groups, and they're providing insight and innovation and the implementation advice that we think we need to be able to shape up that strategy. The groups are advising us on 4 key themes: supply, capability, worker wellbeing, and rural and regional issues. And also they'll guide us on the process of engagement we think is going to be necessary as once the strategy is released, and so that we can really work together on this vision collaboratively. So as I mentioned before, the Royal Commission specified that the workforce strategy must be delivered by the end of 2021, and the timelines for development of that strategy are tight, but I wanted to emphasise it's a first step in what will be an iterative process. So the strategy won't solve all of our workforce challenges, and I know there are many, but it is going to be a really important first step in some of those foundational pieces to build a workforce in the ways that the Royal Commission had envisaged. And I did want to point out, though, that the strategy, the intention is that it will include some immediate and short-term action, because we know there's absolute urgency in the system right now to support the current workforce and think about building a future workforce. And it'll also include some medium and longer-term actions as well. So we really do welcome and encourage your continued involvement in this work, both in the development of the strategy and absolutely then in the implementation of it as well. Next slide. I'll touch now on the Mental Health and Wellbeing Act. So as I've talked about before, the Royal Commission recommended repealing the current Act and then enacting a new Mental Health and Wellbeing Act to provide a legislative framework for the redesigned system. And building on the Royal Commission's very extensive consultation, the department's engaging with people in a number of ways to translate recommendations of the Royal Commission into the new Act. So for example, we invited specific policy proposals through the Engage Victoria website, and that was open between June and August. That work didn't replicate the work of the Royal Commission, but it did focus on policy issues where the Royal Commission gave high-level direction, or where we needed further information to be able to translate the vision into legislation. Those targeted policy areas were discussed in some detail in the update and engagement paper that was on the Engage Victoria website. We really, really do appreciate and thank everyone who's taken the time to provide input. The response from across the sector has really showed, again, just how passionate and committed everyone is to the reform journey. We've had hundreds of submissions through that Engage Victoria process from a really wide variety of people and organisations. We've also attended some targeted sessions to allow for deeper conversations about some of the key policy issues. And through this process, Mental Health Victoria and Victorian Healthcare Association have partnered to deliver 3 really great workshops, and many other groups have been part of that, including consumer and care organisations, which has been fantastic and much appreciated. Next slide. So we're in the process of analysing the submissions and the outcomes of those targeted sessions to inform development of the new Act. We're also working with our advisory structures, including our dedicated expert advisory group, which brings together a range of expertise so that we can incorporate feedback and further refine the policy for drafting the new Act. So once we've done that, we do plan to provide an update about what's happening next for the development of the Act. And over coming months, the bill will go through government processes to enable Parliament to consider the bill in 2022. But as you can see here from the slide, the process really does not end there. There's going to be lots of activity to support implementation of the new Act, and we really will need your input for that. That'll include development of supporting delegated legislation such as regulations and also supporting guidelines. So there'll be lots of opportunities to engage through that. Also, as recommended by the Royal Commission, a review of the Act will be undertaken within 5 to 7 years, and this will be co-designed with consumers, families, carers, supporters, workers and providers. So we'll keep updating you as this work progresses, and although again the timelines are tight, we do think that the new Act will provide that very important enabling architecture to support the new mental health and wellbeing, and so that we can see those better outcomes. Next slide. This is just wanted to touch briefly on our commitment to working with you, and I can't emphasise enough though that we still are in the very early stages. And I mentioned in June at the symposium that the department was being restructured to establish the new mental health and wellbeing division. We've gone live with that new structure from late July, and we're currently operating probably at about a third of our planned capacity. So we're now actively recruiting. I'm keen to make sure we are bringing people into the division with lived experience, both from a consumer and carer point of view, and also really great seeking expertise and experience for the mental health sector. So you might remember I made a plug at the previous symposium, and I really do encourage you, if you're interested, to keep an eye out for some opportunities to work with us. I think it is going to take us until about the end of the year to really build up our capacity and bed down that structure. So quite a bit of work there. Our approach to engagement has been incremental. So back in May, we had the budget briefings. We've been having many meetings with stakeholders across the sector, and we are, and I think Craig touched on this earlier, trying to develop up tools and resources to support our teams in the division in their engagement, and so that this really shaping a culture and that embeds engagement, co-design and continual learning, so that it really does become second nature to us in our work. I did want to flag as well, just our one important part of the engagement is how we communicate with you, and so there's plenty happening in that space as well. We've just went live last week with a revised and refined dedicated website, and so you can see the latest information there about the reforms, and also looking at other ways we can keep informing you about what's happening. And then lastly, we are continuing to shape the broader advisory structures. I talked about this in June as well. It's taking a little bit longer than I'd hoped for us to get there, but I think it is time well spent that we do get that right. So I'll have more to say about that shortly. So next slide, final slide. Thank you. So just in closing, I'd like to thank everyone for your continued dedicated work to support people through some really difficult and uncertain times. And your commitment is pretty incredible, and I hope that that will only grow as we all see some real and positive changes happening across the system, and very early days. But I think together that shared commitment and enthusiasm is going to be really important for us to work together as we move forward. And we're really keen to share information and keep you all informed, as well as then about the opportunities for engagement. So we're still building that capability, but looking forward to it. In the meantime, you can go, there's some links there, have a look at the websites that are on the slide. So thank you again for your continued work, support and contribution, and I hope you have a great rest of today. Thanks.
Thank you very much, Katherine. And just a reminder to everybody that all those slides will be available. There was so much great information on those slides. We really appreciate, Katherine, your time this morning and being so generous with sharing where you're up to with this really important reform process. It was very informative, and as I mentioned, everyone's going to get the slides, so don't worry if you missed anything. You'll get a copy of the slides. So lots of great information there, and very exciting, and great that you have such a good focus on workforce strategies, but also the lived experience, and that there are job opportunities as well. That's always good to hear. So it's a very, very positive and great way to start today's symposium. So we're going to have a short break. We're going to be back here at just after 10:30. So you can see those support lines up on the screen if you do need a bit of help while we're having a little break. But it's a good time to stretch your legs, get a cup of tea or coffee, and I will see you back here at 10:30. Welcome back, everybody. Hope you had a nice little break, got time to stretch your legs. You can hear my little puppy dog in the background, so I apologise for that. If we're lucky, Sammy might make an appearance later on. So now is your time really to get involved much more for the rest of the day. Thank you for the questions earlier in the day, but we're going to be having, for all our panel discussions, we want you to be involved, doing word clouds, asking questions. So I'm going to introduce our first panel, but and then after I do that, we'll give you the code again and the question for the first panel. But this panel is about embedding safety and inclusivity across the new community models of mental health. So we're very delighted to have an eminent panel to talk about this issue. And in no particular order, I'll just introduce them. We have Mischa Barr, the Policy and Health Promotions Manager at Women's Health Victoria, Jackson Fairchild, the Head of Policy Programs for Rainbow Health Victoria, Rashmi Kumar, the Executive Officer of the Ethnic Communities Council of Victoria, and Sheree Lowe, the Executive Director of Social and Emotional Wellbeing Centre of Excellence as well. So I think everyone's online. Looks like everyone's there, which is amazing. Now, the question we're going to be asking the audience, and this is you in the audience where you come in, the question is, what is the most important tool for strengthening cultural safety and inclusivity? So if you can go to that, the menti.com site, and I'm going to do the same thing, and you can start the options you have. There's a couple of different options you can see when you go onto the Menti site. There's different things you can choose, what you think is the most important tool. And then what we're going to see is, we'll see which things people see as the most important. And the options are things like community services, accreditation, minimum standards, inclusivity training, workforce diversity, a whole range of different options. So we'll see, here we go. We can already see some of the answers coming in, which is amazing. So I might just get the panel to each unmute themselves, just so that we can reflect on what we're seeing. So it looks like so far with the answers, what we're seeing is that workforce diversity is definitely coming up as one of the most important things. We'll just wait a couple more seconds. Oh, look, it's powering ahead, workforce diversity. So let's see, I might just get the panel to reflect on that, and then we can go into some of the other issues as well. So I'll start with Mischa. So it's clear from that the audience really sees workforce diversity as so important. How important is workforce diversity? I'll get each of the panelists to reflect on this. I'll start with Mischa though.
Yeah, sure. I guess from a women's kind of perspective, I guess the key issue in terms of gender composition of the workforce is more around the seniority of women within the mental health workforce. So there are plenty of women, obviously, within the mental health workforce and plenty of women with lived experience. But the issue is more around how women are represented in senior roles, and particularly in senior clinical roles. So one of the findings of the interim report of the Royal Commission was, for example, that there's very disproportionate underrepresentation of women, for example, in senior clinical and psychiatrist roles. So I guess from a sort of gender or women's perspective, it's probably more around the types of roles and the power dynamics between clinical and non-clinical services. Women are more represented, for example, in non-clinical services, rather than, I guess, the representation of women per se, but that would probably be different in terms of anything more intersectionally. And I'm sure that Rashmi and Jackson and Sheree will speak to that.
Okay, maybe, and Jackson, your viewpoint on this issue, on the issue of diversity.
Thanks, Sophie. Look, I think it's a very important issue, and I think when I think about this question, I also think about you know, that having people on the team isn't just often isn't just enough to achieve that kind of impact. They themselves need to feel safe and welcome and included within the structures, policies and practices within the organisation. And all of those other elements around accreditation, partnerships, minimum standards, and an understanding of research data and evaluation can really help create a space where people can feel like they can express themselves, be themselves. For LGBTIQ people, be out about who they are and celebrate who they are in the workplace. Because just having someone on board isn't enough to really create that kind of culturally safe space for the different communities that we really need desperately to have represented across the workforce. And as Mischa touched upon, particularly those individuals who may have multiple experiences of marginalisation may not feel safe in a workplace where those policies and practices aren't in place.
Well, look, we're seeing some different answers coming in, which is exciting. Rashmi, we'll go to you to talk about this issue. We might just also reflect on there's some other service partnerships and specialist community services. So there are some other issues that are popping up as really important as well. For strengthening cultural safety and inclusivity. But from your point of view, what's your, oh no, it's all changing around, goodness me. But what's your, what from your point of view, what do you see as the key tools for strengthening cultural safety and inclusivity?
Thank you, Sophie. And before I answer the question, I'd just like to acknowledge the traditional owners of the lands that I'm joining you from. I'm joining you from the lands of the Wurundjeri people of the Kulin Nation, and I'd like to pay respects to their elders past and present, and also just to acknowledge that I am not the executive officer of ECCV. Didn't realise that I'd been given a promotion this morning.
Okay.
I'm actually the policy and advocacy manager.
Oh, well, there you go. I'm pretty good at doing that. I often give associate professors a full professorship. So that's, but thank you for that. But yeah, so tell us your point of view.
I think with the responses jumping around a little bit, I think maybe that sort of reflects that a lot of these elements are probably quite important at different times and in different ways. So I think each of the tools that are outlined in the poll have an important role to play in increasing cultural safety and inclusion. I think I might just reflect on the partnerships and on the first option. And so it's a little bit hard for me to see the poll on the slide.
That's okay. The typeface is very small, but that's fine. It says specialist community services, accreditation, service partnerships, minimum standards, workforce diversity, and integrated research, data collection and collaboration, evaluation.
Yeah, I would absolutely agree with Jackson's comments around the need for cultural safety within services for the workforce diversity to be effective and successful. And I think that in order to make that happen, some of these other elements are important as well. I think not just diversity of the workforce, but diversity of service models, service types, and options for people with a lived experience to access support in a range of ways, which goes to the first option, which is around specialised and community-based types of support. And certainly from the multicultural sector, that's an area where there is a gap, and there are service models and service types that would probably be more culturally responsive or culturally relevant to many people from migrant and refugee backgrounds that we have yet to see those opportunities being realised.
Fantastic. And Sheree, we'll go to you. And before we do Sheree, I just wanted to mention to the audience that after we talk to Sheree, that there's also I've got some questions for the panel, but there's the opportunity for anyone in the audience, if you'd like to ask a question, you can go to menti.com and ask your question, and we'll get to those in the final part of this session. But first of all, Sheree, we'll go to you. So what do you see as the most important tools for strengthening cultural safety and inclusivity, particularly if we're talking about these new community models of care?
Thanks, Sophie. And before I start, I would also like to acknowledge the traditional custodians of the land in which we gather, and acknowledge the Aboriginal lands on which we all dial in from today, and pay my respects to elders past and present. I think that the question is such a huge question, right? There's so many angles on how we can tackle cultural safety within any space. Today we talk about it from a mental health context, but when we think about cultural safety and what components and what elements sit within that, there's kind of quite two distinct focuses within that when we think about system structures and organisational ways of doing, and then also from an individual context. So when we talk about cultural safety, we need to look at both of those. So when we talk about being able to prioritise and being able to create approaches that enable cultural safety, that's when we start to talk about things that are really important. So when we think about what does the legislation say, what are our accreditation in our health courses delivering, but also what are the standards that are governing our clinical, professional and quality standards. So that's kind of, if we think at a very high level, they're the things that are going to start to guide and drive consistency within this space of being able to, if it's not within a standard, then we're not going to measure, and how do we know, are we going to drive that change? But also when we talk about changing structures and systems, and from an Aboriginal context, those structures and systems kind of really sit with power imbalances, and also systemic racism that kind of sits within that, and structural racism. So there's a lot kind of bandied within that. But we also need the people to be able to build their skills, knowledge, their understanding and awareness within this space as well. So you kind of can't have one without the other. I think if we go back to the very first question and that reflection, diversity within our workforce and diversity within community just in general is a really critical part. Being able to have diversity of opinions, viewpoints, and being able to contribute to those solutions, having multiple people around the table coming from different perspectives are going to give us the best solution for what we're looking for. So I think that there's lots to kind of go into that, but that's my initial kind of thoughts from that perspective.
Oh, that's great. And just a reminder to the audience, the Menti questions open now. We're starting to get a few questions coming in, which is great. So if you have a question for the panel, jump onto menti.com. You can see the code on the slide, and we'll get to your questions at the end of, or the last part of this session. Another important question that we wanted to cover was how can these broader community-based mental health groups link into the work of specialist organisations drawn from the communities that they're seeking to support. So maybe we go back to we'll start again with Mischa. So how do these broader community groups that have been set up, how can we make sure that they do link in and are sort of strongly connected to specialist groups? And I'll get each of you to reflect on this question.
Yeah, sure. And I might just quickly flip back to the previous question, if that's okay, Sophie, because I would absolutely reiterate what the other panelists have spoken about in terms of a whole of system approach. So obviously I spoke specifically about workforce diversity, but I would absolutely agree that actually we need all of those factors and a whole of system approach. From a women's perspective, for example, we know that women have historically been excluded everywhere from, research into effective treatments in mental health, through to the curriculum, through to, the workforce itself. There are particular attitudes that are still exclude women's perspectives, that kind of thing. So we have a whole mental health system that is steeped still in patriarchy over, many centuries. So really we need a whole of system approach, and of course workforce diversity and some of the other factors, those tools that were mentioned in the poll, are absolutely essential. but thinking about that actually as a whole of system as opposed to one factor being perhaps more important than another. But in relation to this particular question, I guess that the key thing that I'd really like to highlight from a women's perspective is the intersection between gendered violence and mental health. So we know that gendered violence is a massive issue for women and girls in our society, and in fact creates the largest the largest contributor to the burden of disease for women aged 18 to 44. We know that mental health impacts are the largest part of that disease burden. But what we don't necessarily see at the moment is strong integration between services, family violence, sexual assault services, for example, and mental health services. So some of that work has started to happen following the Family Violence Royal Commission, but there's still a lot of unfinished business in that regard, and thinking about how, particularly as we're building, for example, these new local adult mental health services, how we can build integration with some of those family violence and gendered violence response services is going to be really critical in that space. At the other end of the spectrum, we have a fantastic network of women's health services across Victoria. We do a lot of work around addressing the social determinants of mental ill health from a health promotion or a primary prevention lens. And there's a real opportunity there in terms of addressing the social factors that drive poor mental health for women and for a whole lot of other groups, to work, for example, with that network of women's health services. We're already doing a lot of fantastic work in that space.
Excellent, good point. Thank you, Mischa. And Jackson, I'll just get you to reflect on that as well, about how these community groups can make sure that they support back, or they're linked to specialist organisations to make sure that there's good coordination and links between the two.
Yeah, absolutely. Look, it's absolutely critical that what we'd refer to as mainstream organisations that serve the whole of population, and specialist services that support particular communities work side by side to work in parallel. Private Lives, which is Australia's largest study of the health and wellbeing of LGBTIQ people, showed that LGBTIQ people have a diverse range of preferences about the kind of services they would like to receive. Some would prefer to access an LGBTIQ community-controlled organisation, whereas others would prefer to access a local mainstream organisation that has demonstrated itself to be inclusive through an accreditation program or a similar sort of model. Like the rainbow tick.
You want the option, so ideally the option exists to either work within the specialist, get help within the specialist organisation, or a more mainstream one.
The freedom of choosing, just like everyone would hope to be able to have. People have their own personalised preferences. And sometimes when we set up a specialist program and think that that's the solution to all of our problems, it actually really limits the freedoms of community members to be able to choose what's right for them, whether based on geography, the kind of community support they receive, whether they prefer a degree of anonymity, or whether they just want to go to the place down the street from them that they know someone is good at. But creating that kind of collaboration and work requires further investment, and we need to be able to see in the future, for these community centres to be successful, LGBTIQ community organisations are often called upon to collaborate and support and provide secondary consultation, and it's critical that they are also provided with the resourcing that's needed to be able to sit in on multidisciplinary meetings, provide secondary consults, provide advice on improving safety and inclusion within services, because they have a tremendous practice, expertise and wisdom built on generations, and a deep understanding of the particular needs and strengths of those communities, and that ongoing relationship is where a lot of that really powerful work can happen. A client may come in through the mainstream service and then choose to move into a specialist service, or vice versa. Clients don't just come into one service. So we need those agreements, we need processes, we need to map those processes. And for LGBTIQ people, what we really need is a consistent pathway. Often someone will go to a service and, apologies, I'm losing my voice thanks to the new pollen coming in for spring.
You're right, that's why I've got my cup of tea here.
We know that someone may access a service under a particular banner and have a fantastic experience, tell all of their friends, who then may decide to access that service themselves. But if there isn't a standardised measure of an expected quality or consistency across both an individual service and a series of services such as these new centres that may have similar branding across different geographic locations, it's reasonable for someone to expect a similar standard of care between centres, but that often isn't the case. And we need to create benchmarks and quality systems, which is why accreditation programs can be so powerful, because they put in the kind of, I like to describe it as an immune system that helps organisations become more inclusive. And in order to get there, consultation is absolutely critical. There needs to be processes in place where the community voices are heard, where that's not just based on a small group of people that they speak to regularly, but rather a consultation with the actual clients who regularly use their service, who may be not just LGBTIQ, but maybe migrant or refugee background, they may be disabled people, they may be older people, younger people. Those consultation processes need to reflect the communities that that service is working with, and community organisations can play a great role in supporting that consultation and that two-way flow of information, so that services are really on top of what they need to know as we continue to develop our understanding of best practice.
Great, okay, and Rashmi, I'll get you to, we'll just briefly, Rashmi and Sheree, reflect on this question about how can the broader community-based organisations support the work of specialist organisations, and all that there's good linkage between the two. And then we're getting lots of audience questions, so we might go to those then next. But Rashmi?
I guess I'm probably following from some of Jackson's comments is actually maybe challenge one of the assumptions behind this question, which is that there's a separation between community-based mental health services and other specialised service providers. And I think as long as that separation is there, that we won't achieve what we want to achieve. And I think when we're talking about something like workforce diversity, that needs to be at every level of a service, including in leadership, at governance levels, as well as system level. And so I think that we would start from a starting point of wanting to maybe question why there needs to be that separation, I guess, and the need for actual involvement and understanding of the expertise from the multicultural sector. We probably are also involved in providing a lot of secondary consultation and unrecognised and under-resourced support that is not being addressed through the mental health system. And what probably many of our members have reported is that many community members will approach ethno-specific or multicultural organisations first for mental health support, and they don't actually trust any mainstream services, and probably wouldn't even approach any of these community-based services. And so to actually achieve an outcome which is reaching the community that we're meant to be serving, we kind of have to rethink that kind of separation. The other comment I'd make about this idea of links and the idea of separation is that what we also know is that different levels of funding, different guidelines, different legislation and governance processes create service level barriers that are really, really hard for people in the community to navigate, especially if they have limited health literacy, they don't have experience of navigating these kinds of complex systems. And this is especially true for people from migrant and refugee backgrounds, especially if they're more recently arrived. But it can also be the case for people who've lived in Australia for a long time. And so I would say that the capacity to actually create that coordination is really, really critical for the system to be actually accessible and for people to get the support that they need and when they need it.
Okay, fantastic. And Sheree, we'll just get you to briefly touch on the same point about the linkages between the community-based organisations and the specialist groups. How do we maintain that they're supporting each other, that they work well, together, and that that there is that choice for people to either choose the specialist group or the more community-based one?
There's a lot of commonalities in what has already been said, but I guess that what's really important to acknowledge from our perspective is that the current system is insufficient to meet the needs of Aboriginal and Torres Strait Islander people, and has been for a really long time. But also thinking about it from a strength-based perspective, that our Aboriginal community-controlled organisations at local levels have been advocating and providing leadership of collaboration and partnership for before I was even born, so over 50 years. And I think that building on that, the unfortunate thing about being able to advocate and provide leadership is that people need to be in a space to be able to listen and understand. And I think that that's where we start to fall short. We come from a history within Australia of not a shared history and a shared understanding of the impacts of colonisation, particularly to Aboriginal and Torres Strait Islander people. So there's a whole range of things that can happen at a localised level, but I think that what's really important for us is to be able to really hone in on the holistic approach to health and well-being, and that for us encompasses mental health as well. And our National Social and Emotional Wellbeing Framework sets out some really clear guiding principles for us about what could help in being able to work together at any level. And that comes in the form of being able to recognise that health as holistic, because we don't actually recognise that necessarily, and having a Western dominated version of health they clash a little bit in that space. We also need to recognise the right of self-determination, and that's so critical on a whole range of levels, and it's something that we talk about and speak often about, but putting that into practice is a really big challenge and an ongoing challenge. We also speak about the need of cultural understanding, understanding the diversity within Aboriginal and Torres Strait Islander communities is really important. We're not all just one group of people. There is over 200 language groups that have their own ways of doing, and I think it's really important to recognise that diversity within that. It's really important to be able to understand the impact of history and the trauma and loss of colonisation and government policies and legislations that happened post-colonisation. We have to recognise, and again, as a nation, we don't like to talk about this, but we do have to recognise the impact of racism on people accessing services. And until we become mature enough to be able to talk about that as a nation collectively, we're not going to be able to address that as a barrier, which is huge in service delivery, service quality for Aboriginal and Torres Strait Islander people. We also have to understand the recognition of centrally, like a kinship, and how that sits centrally to our well-being, and also just being able to recognise the strengths within Aboriginal communities, because often we come at it from a deficit model. So when we think about those principles as precursors to before we start to do any work together, that there is this kind of expectation that you can come to the table in acknowledging those ways of being to move forward.
Thanks, Sheree. Now we've got quite a few questions, so we might just try to get through them as quickly as possible. So I won't go to each panelist because I don't think we'll have time, but one question which is important, which is we have, I think it's important to cover. We might go back, ask Mischa, maybe this one. It's talking about this audience member saying there's huge workforce shortages, and a lot of people in mental health workforce are suffering from burnout and compassion fatigue. And they're asking, how do we keep the current workforce and encourage more, people to come into a workforce where there's already a lot of burnout? And I just would mention before you answer, Mischa, that I write a lot about burnout actually, because it's something that affects lots of people, and I've been through it myself. So, and if people are interested in more resources on burnout, I put quite a lot on my Instagram account, so you can go there, and there's lots of scientific papers on burnout if you're interested, because it particularly affects the caregiving professions, like people working in mental health and health generally. But so, Mischa, just from your point of view, how do we hang on to the workforce that we've got and encourage more people to come into the workforce, given that there are levels, high levels of burnout and compassion fatigue?
It's an excellent question and a huge question. It sounds like you have plenty of expertise to share yourself on this, Sophie. But I guess, I obviously the mental health workforce, obviously the conditions of work are critical in that space in terms of, you know, this is an under-resourced, still underpaid, many of the workforce, the parts of the mental health workforce. It's largely a feminised workforce as well. We know that caring professions tend to be undervalued and underpaid. We know also that this workforce and all workforces, many people obviously have their own lived experience, either as consumers or as carers. They're often doing unpaid care work on top of paid care work. So I guess from my perspective, we'd be looking at a, you know, putting a kind of a gender lens, we would say, across this and thinking about actually how does inequality across people's personal and professional lives actually impact their experience of work. Yeah, you know, I guess we'd sort of be looking at that kind of structural level and looking at what kind of supports do people need to address some of that sort of entrenched kind of inequality in terms of financial disadvantage, in terms of disproportionate share of care that people are undertaking at a kind of structural level. It's not an easy kind of fix, but thinking actually about the different social and personal and professional roles that people play, and as I think we were talking about in a previous session, recognising people bring their whole selves to work and being able to balance the work and life challenges that we all experience.
Yeah, good point. Well said. And I might move on to another question, and maybe we'll go to Jackson for this one, because you mentioned accreditation, and this audience member is asking that a person's experience is often based on luck, as in the person who meets you at the door. How do we police or, you know, audit accreditation standards, noting that they're saying that at the moment they think that the standards and the accreditation isn't really great at the moment. So how do we ensure that there is that quality of care across different services, particularly with these new models that are being set up at the moment?
It's a great question. Thanks, Sophie. In terms of, you know, how do we create consistency? You know, just to speak about the Rainbow Tick, which is the set of LGBTIQ inclusion standards that we are the standards owner of, and has becoming, you know, increasingly taken up in the mental health space. These standards address 6 different, I guess you could, you know, kind of domains within an organisation. It talks about the policies and procedures. We talk about the workforce capacity itself. We talk about what are the mechanisms to ensure LGBTIQ cultural safety. And in this, we're talking about looking at and developing an organisation at all levels. So we're looking at what are the physical spaces people see when they walk into, what are the messages they hear when they look, or they see when they look at a website or see advertising for the organisation. Do they feel included and welcomed? Do the forms ask questions around their identity and experience that appropriately represent them? Do the people looking after them or providing care have the requisite training and knowledge to be able to provide that kind of safe and inclusive care? And above all of that, are we dedicated to ongoing learning and listening as we move forward? And I think that's one thing I would just emphasise the most. Organisations that are the most successful are organisations who are welcoming of feedback. They are welcoming of, they're not defensive. They celebrate feedback as an important opportunity to grow and learn and reflect. They keep a good register or record of all of that feedback, and they actively seek feedback out from their staff, from their clients, and from potential clients through consultation processes that allows them to continue to work on to be better, because we can't just go through and perfect everything straight away. That's not how the world works. We can, however, dedicate ourselves to ongoing learning and reflection and what we would call quality improvement. And when your quality improvement processes include things like LGBTIQ communities, when they're examining, are they safe for Aboriginal communities, when they're safe for migrant and refugee communities, when they're safe for women, and are we looking at and considering how someone with multiple experiences or identities may experience your service? That's when we start to see real success and people feel really celebrated. And that experience can actually be really healing. It's not just an absence of harm. I can speak for myself. When I go into a service where I feel really seen and celebrated, not just included, but celebrated by the service that's seeing me, And I can see that present in all these different ways. It's not just one good person with a rainbow lanyard on. It's in the forms, it's in the policies, it's in the speeches given by the board and the CEO. I feel a little bit healed from previous experiences that have been less than stellar.
Oh, that's great. Thank you so much for that. Now I might just ask Rashmi this question. Someone in the audience is asking, and it's talking about the fact that these community models will be based in certain areas. It says, is there a danger in that approach to local service design, leaving it up to the regions themselves to determine the models, that it might risk leaving out the needs of more diverse communities? Rashmi?
Well, I think there's diversity across our state. Victoria is the most culturally diverse state in the country, and the actual catchments for each of those local area services will have community-based and ethno-specific organisations working in those areas. We've seen in our settlement program, for example, that there is much more of an emphasis on regional settlement. So there are some very well-established communities as well as more newly arrived communities right across the state. So I would say that the first starting point needs to be actually understanding the population that the service is attempting to reach, and mapping who those agencies are. So I think that it's maybe an assumption that we only have diversity in Melbourne, and there is quite a lot. But there are many communities that are out in regional Victoria who also will need access to support, and you know, maybe at a different point in their establishment and settlement, depending on their settlement process and history of migration to Australia. And so those factors need to be considered when establishing these kinds of the service models and the processes for community engagement. And I would say that actually what the process should involve a co-design, and what that process looks like may be different for each region, depending on who is in the catchment for that regional service.
Yeah, that's a very good point. So Sheree, I might just ask you this question, and the audience member wants to know, is there an established model for establishing cultural safety that you're aware of? Is there, I mean, I guess they're asking, is there a best practice that we should be looking towards and saying, this is what we need to be doing because we know it's worked in this setting or that setting?
I think there's a couple of elements when we talk about cultural safety from an Aboriginal and Torres Strait Islander perspective, that it is defined, cultural safety is defined by Aboriginal and Torres Strait Islander people and their experiences. So that in itself will create a bit of ambiguity around what cultural safety looks and feels like. And I think that that's naturally where people want to head, to be able to say, this is what it means, this is what it looks like, and this is how we can address it. It's not as simple as that, because we then go back to that diversity of experiences that Aboriginal and Torres Strait Islander people have experienced, and that's kind of where it centres around. So being able to have some foundational elements to what needs to be addressed. So when it's what I said earlier on in that opening piece around, when we talk about cultural safety, and Jackson, you spoke about this a little bit from the rainbow tick perspective, is that we need to look at it from a structural point of view or an organisational point of view, and what we have in place that that are barriers to being able to enable cultural safety. It's about different ways of doing and being, and how that is reflective in organisational values and organisational ways of doing. That's reflective in your policies, procedures. In a health context, it needs to be reflected in our accreditation and standards and what that looks like, because we're setting a consistent message about this is what it looks like and feels like. It also needs to then be coupled with being able to build individual capability in this space. So it's about building knowledge, it's about building skills, it's about changing behaviours and views of what currently happens. So when we think about that, particularly from an Aboriginal and Torres Strait Islander point of view, There's probably 4 key things that we need to start to think about and what needs to be addressed when we talk about that from an individual perspective. So we need to acknowledge colonisation, systemic racism, and how that sits within our current health sector and how that impacts. We also need to be able to look within ourselves and understand our own biases and how our culture interacts with the other culture. So being able to understand that. But for us, it's also about being able to recognise the importance of self-determined decision-making. And as I said before, that's really hard because it's about the power shifts and the dynamics and actually coming at the table without preconceived ideas. It's actually been allowing other people to make those decisions. And when we think about how our current service system is structured and is funded, there's systemic things that sit within that which don't necessarily enable that when we think about funding agreements and what that looks like, how we measure success, at what point of the conversation people enter into. So that's really critical as well. But then the last point is about being able to foster safe working environments so people, and providing that leadership so people can bring their whole self to work. People can feel safe within community. People can, I think Jackson, you mentioned it before, that there shouldn't be a wrong door when people are needing and ready to access help and services. It shouldn't matter whether it's a specialised service or a mainstream service, that they should get that care and response that's going to meet their needs.
Okay, look, we've only got a couple of minutes left. So what I might do, I might just go through each of the panelists just to really get you to give one last thought for the audience, the key takeaway that you would like to leave with the audience about your view about how best to embed safety and inclusivity in these new models. So just one final thought from each of you. Mischa, we'll start with you.
Thanks, Sophie. Yeah, I guess the final thought I'd like to leave people with is around the need to actually address the social risk factors that drive poor mental health for women, but also for a range of different populations. So what women tell us is that they want the mental distress that they experience to be understood in the context of their lives. So I've talked, for example, about the high prevalence of gendered violence, for example, caring responsibilities. And I think what that goes to is both the need to actually address those sources of social disadvantage and inequality from a primary prevention, health promotion perspective, but also the need for multidisciplinary approaches for integrated care across those different services where women might be experiencing financial insecurity and disadvantage, they might be experiencing gendered violence, they might have legal concerns, they might have housing and homelessness issues. And we can't continue to kind of pathologize and individualize what is actually often the impact of sort of social inequalities and discrimination that people experience. So I think that's the key idea that I'd like to leave people with today.
Okay, thanks, Mischa. And Jackson, what's your final idea that you'd like to leave with the audience today?
Plus one to everything that everyone said, and what Mischa just said is a big part of what we're talking about in Rainbow Health at the moment around addressing the drivers of why we see these poorer mental health and wellbeing outcomes for LGBTIQ communities. It's incredibly important to look at social inequality and to address that both in the advocacy of your organisation, collectively as a sector, and in the lives of the individuals you help. But I'd also just like to add there is that as you step on this road to do this work, I would suggest find ways of building connection and of building a sense of positive energy and celebrating change as you go. In our how-to program where we support organisations on the Rainbow Tick journey, we talk about celebrating wins and the importance of both having a big overall plan, but also achievable smaller tasks along the way that are appropriately chunked up, that individuals can take ownership of and celebrate when they win. Both in the benefits for themselves and the collective benefit for the community and other staff, because this is big work. We are talking about working in some occasionally edgy topics that can bring up some difficult stuff. And it's important that we learn to be curious, to put aside our own programming and feelings around this sort of stuff, and to celebrate as we move forward, as we continue to build more inclusive and safe services for our communities.
Okay, thank you, Jackson. Yes, I think always celebrating the small wins is great advice. So thank you. Rashmi, what's the final thought you'd like to leave with the audience about safety and inclusivity?
I think that we're embarking on quite a big reform process, which can be quite challenging and frightening for some people, can be stressful, and we know that this kind of scale of reform will create a lot of change. And within that context, I would say there's often a bit of a temptation or a tendency to try and protect one's own patch. But really what we need is an expansion of the patch and opportunities and capability and capacity created amongst in areas where they haven't been before. And transferring power, transferring resources can be quite challenging for established institutions and systems and organisations. But at the end of the day, I think we can create win-win situations. I think we can create solutions, and I think we can create the capacity to actually meet the needs of the community and address the social determinants of poor mental health. And so I would say a key thing to take away is is to look at for those opportunities and look for how to come towards those opportunities with a sense of openness, even amongst all the challenges that this change is creating.
Okay, thank you, Rashmi. And just finally, Sheree.
I think the lasting thing that I would like to say is just that this is an ongoing process, the reflectiveness of it. There isn't necessarily, when we talk about inclusion, sometimes you may be going down a path of, in building your knowledge and awareness, that you may feel the more you know, the more you don't know. And that's okay. And that's a part of the growth in being able to include. And I think that learning with humility is a really important aspect to that. And I think that being able to even learn from mistakes or different ways of doing or getting things a little bit wrong is really important. It's important to continue to grow and to learn from that and that ongoing nature of it all. I think also from an Aboriginal and Torres Strait Islander perspective, I just like to put it out there to everyone that, you know, we're 3% of the population. The data really highlights the disparity and gaps between Aboriginal and Torres Strait Islander communities and the wider community. We can't create the change on our own. We know the solutions. We're having Aboriginal-led solutions is really critical, but we can't create the change. The system and the size of the change that we need, we can't do that alone. So we need our allies. So I would encourage everybody to be able to start to learn about our true history, being able to understand how that influences us and how we interact within community, and how we can grow and learn together and being good allies to be able to advocate, to work together to reduce that disparity and gaps.
Okay, look, that's great, Sheree. Thank you so much. I think that was a really fantastic panel discussion. I really love the focus on growth, on looking at things with curiosity, being open to feedback, understanding that we need to collaborate and work together for real change to happen. So please give everyone in the audience, give them a virtual round of applause. Thank you so much. Thank you, Mischa, Jackson, Rashmi and Sheree. That was really wonderful. And yeah, thank you so much for your time. It was a really great discussion. I think the audience would have got a lot out of that. So thank you very much. We're now going to move on to our next discussion, which is a fireside chat, which we're going to have 2 of today, which is fantastic. And the fireside chat, we're going to have sort of really continuing the theme that we just spoke about inclusivity and cultural safety. Now we're moving sort of to a slightly tangential but related topic of intersectionality. And we're delighted to have as our speaker and to have a bit of a chat on this is Dr. Adele Murdolo. She's the Executive Director of the Multicultural Centre for Women's Health, a voice for migrant and refugee women's wellbeing in Australia. She's from an Italian background, which is great because Italy is my second favourite country to Australia. And she's led this centre for 17 years. She has a PhD in history, and I did history at uni. So again, another big tick for me, and women's studies. So she's a researcher and an expert in women's health, feminist history and activism in Australia. And we're delighted to have her with us today. So I'm going to be asking a couple of questions, but then just kick us off, we'll do we'll go over to you in the audience. And if you can see the slide that's up at the moment, it's what are the key intersectional needs in the new system? So if you want to give us your feedback on that from the audience point of view, what do you see as the key intersectional needs for the new system? And then when we get that up, we can get some response from Adele. But and I'll just get it up on my phone so I can see what everybody's saying. But while we do that, Adele, I might just ask you, how important is it to give a platform to migrant women to allow their perspectives to influence the development of the new models of care for mental health? How crucial is that? And welcome, I should say first.
Thank you so much, Sophie. And I'd like to actually begin by acknowledging that I'm here on the lands of the Wurundjeri people of the Kulin Nation, and I would like to pay my respects to elders past and present, and to any Aboriginal and Torres Strait Islander people who are on this in this session today. So, look, I think it is so important for migrant and refugee women to be not only a part of the conversation, but leading the conversation about their own mental health. And this is something that's so important to our organisation, which is run by and for migrant and refugee women. And our little slogan is migrant women's health in migrant women's hands. So that is really relevant to the way that we approach all of the health issues that impact on migrant women, and in this case, mental health. You know, we are the ones who really understand what our life circumstances are and what does create, on the one hand, mental ill health or mental distress, and the higher rates that migrant women are experiencing in some mental health conditions. And we also have a really good handle on the other side, how we can actually make that situation better, how we can reduce some of those generating factors that I think were talked about quite a bit in the session before. What are the social determinants that can generate mental ill health for migrant and refugee women? So in other words, we know what causes the problem, and we have some really good solutions for resolving those issues. So we really want to be at the table, and we've got lots to contribute.
So we can just see, can you see up on the screen there that some of the words that are coming in terms of the key needs are things like family inclusive, culturally safe. So would you agree with those? How important are those issues? And is there anything that's missing that you don't see?
Right, look, cultural safety is such an important component, and I think Sheree spoke so articulately about what that means. And I think we can learn so much from the way that Aboriginal and Torres Strait Islander organisations have approached that issue, that it's not just about, say, you know, training up your staff in cultural competency. It really is a whole of organisation approach that goes from having a look at your systems and structures right down to, you know, how the staff behave in their interactions with people who use the service. Family inclusive is an interesting one. I can see that's really big. And, you know, on the one hand, I can really understand where that comes from, because, you know, when you migrate, family is one of those, unfortunately, things that you can lose on migration. And people at the moment, especially with COVID, are really suffering because they're not able to be with their families. On the other hand, family inclusive can sometimes not be appropriate in when you're talking about delivering a service. So I think we need to take into account the different family forms and experiences that migrant communities have in relation to their families in terms of being separated. There are some communities where you might have more a multi kind of family. You're living in a family with a larger kind of extended family living in the same household. And you need to take all of that into account, but we can't assume that family is a safe place for everybody.
That's that's a really good point, isn't it?
That's right. That's right. So I think in terms of that's really important to be responsive and understanding of the situation. So go ahead.
Yeah. Sorry, Adele, you go.
I was just going to say some of the other words I can see there: integration, humility. I love openness is really important, and yeah. So I think they're great words, and many of them would make a big difference in organisations in terms of embedding an intersectional approach.
So we might, I'll put a couple of questions for you. We might move on to, if the audience would like to ask a question, we'll pop up the Menti slide, so you can ask your question to Dr. Murdolo if you'd like. But I wanted to ask you if you could just share some practical tips or your thoughts about any practical ways that we can ensure that the intersectionality is included in the reform process.
Sure, Sophie. I think that's a really good question because, you know, this is really an opportunity we have to make a difference and set up a system that really works for those who need it most. And I think that's probably one of the important components of intersectionality that, you know, you need to develop a system that works, but with a focus on those who are most disadvantaged. So you're looking at the intersections of different forms of discrimination and how they impact on people in the community. So if you look at the intersecting forms of discrimination, so you look at the ways that race discrimination intersects with gender discrimination to create vulnerabilities, to create and generate ill health at times, and to generate disadvantage. So the first thing that you need to take into account is, you know, how do we develop a system for those who are the most disadvantaged in our community and who are going to have probably the most difficulties in accessing mainstream services. So I think that kind of can focus you in terms of intersectionality. The second thing, I guess, to take into account is that it needs to be a whole of organisation approach that goes from the governance to the management to the way services are delivered and the way people experience the service. So the workforce that you establish for that service, as well as the kind of training and ongoing capacity building that you deliver. And doing any one of those things in isolation from the others isn't really going to have the impact that you need. So you need to make sure that your governance is equitable. And I think this is, you know, it's interesting looking at that word cloud, and we have talked about things like safety and inclusivity in the previous session. Also words like diversity and equity. All of them can be a part of intersectionality, but it's really none of them are enough.
Yes, on their own.
On their own. And within organisations, none of those concepts. So you can have a diverse workforce, but it's not going to be enough without equity within the workforce. And also looking at your governance structures. So who is it that's got the decision-making responsibility within the organisation? And do you have the people who are going to use your service represented within those decision-making structures is a really important question as well.
And sort of knowing what you know about the process so far and where we're up to in terms of the reform process and developing the new community models of care, how satisfied are you that what you just mentioned, all those really practical things that you just mentioned, that's going to happen, that's going to be part of what we're going to be seeing in the future with these new centres and the new community models?
Look, so far, what I've observed in the reform process has been a real openness and a real willingness to get this right. So that's a fantastic start. And I've had lots of fantastic conversations with people who are in decision-making roles who completely get it and want to make sure that this reform works and that it works for those most marginalised. So that's a fantastic start. What I haven't seen yet are the kind of practical manifestations of how all this is going to pan out. So I think now is probably a time where we start to think about putting in place some standardised requirements for workforce. For example, a requirement that the workforce matches the demographic of the hubs, of the centres, and that there is equity in in the workforce employment practices and recruitment. So I think, and that might well be happening, but I'm just out of the loop. But I think now's the time to really think about what is it that we can standardise across all of these hubs, and what is it that we can tailor to make sure that it is responsive to the community that it serves. We've got 6 hubs that are going up now, and they are really good opportunities for us to put in place some really, learn from what we know already, put in place some good systems and structures, and then evaluate. Making sure that we've got an evaluation plan that asks the question, do these services respond to the community needs, making sure that they address the most marginalised. And then we can learn from that and, roll out from there. So to answer that question, I think I'm really hopeful. I've seen some fantastic starts, and now's the time to make sure that we put the systems in place. And just one final thing, one thing that I'd like to see right now, and this kind of refers to a comment that Jackson made in the previous session about how organisations like Multicultural Centre for Women's Health and LGBTIQ organisations and women's organisations are asked to participate in the reform in making sure that the reform is appropriate for marginalised communities. And so now's the time really to fund our organisations so that we can actively participate without needing to draw on our existing resources, which are already stretched in the middle of a pandemic. So I think that's one really important move that could happen
well
right
to say
now.
we want those voices there, but you need to actually facilitate it financially to make that a possibility.
Absolutely.
So we've got a few audience questions, which is great. So we might just quickly go to those. And a question here is, how do we reach communities where mental health issues are held within families without access to services and where women are left to take on intense support roles? And just before you answer, I did read a quote where you were quoted talking about the pandemic, where you were saying that migrant women were affected disproportionately in the pandemic because they've got higher levels of domestic duties and family support. They're at higher risk of family violence and social isolation, yet are less likely to have the information, support and services they need, which I thought was a really good point to make. And this question really goes to that, particularly when people are not, women may not have access to the support that they need, and everything's sort of kept within the family, which goes to your point about what you said about family may not necessarily be a safe space for some women.
Absolutely. Look, I think that that's something that we really need to consider, that there's a lot that isn't in the public realm. There's so much that is happening in the family, and that women are bearing the burden of that. And, caring for others and often putting their own health concerns after others. So they'll, deal with, what's happening for the kids first, and then we'll deal with what's happening for the partner, and then they'll kind of think about their own health. And look, I think we need to really change the way that people understand women's health so that it's prioritised and we understand how at the centre of a family women's health is. So, you know, I think we need to make sure that there's more information out there about mental health. We need to have programs that reduce stigma, because that's something that does, you know, keep that issue in the family, and women are often at a real loss for who they can talk to and where they can get some support. But radiating out from the family, I guess it's about the services and supports that are there. A lot of the reason why women take the burden on for themselves, it is because of gendered roles within families, but it's also because simply the services aren't there that are able to respond to migrant women's needs. So we need to have psychological support that's accessible, that's affordable, and that is delivered in multiple languages so that women can actually use those services. Looking more broadly at the community as well, social isolation is a big issue, and that's something that we can only address by building strength in communities, by putting resources into opportunities for women to come together in positive ways that you know, can support them to look for work, or support them to you know, look after their kids, and you know, all of those really important aspects of life that if you're in a situation where you're quite isolated, there are language barriers, you're just so focused on your family, then it can be really difficult for an individual woman to cope. So community strengthening is one really important, I think, piece of this jigsaw puzzle.
And look, this is an interesting question that someone in the audience wants to know. They're asking, how optimistic are you about the understanding and commitment to these reforms from spaces outside of health, but ones that regularly intersect or feed the determinants of health, such as the justice system? So the things that we've talked about that are needed within health, how optimistic are you that those sort of understandings can exist in other areas like justice that do really feed into the determinants of health?
That's a great question, because there is so much. I mean, really, in many ways, the reforms sit more outside of the mental health system than they do inside it. So I think that's a great question. Domestic violence was something that Mischa mentioned, or gendered violence more generally. If we were able to address gendered violence through primary prevention programs, that would really go a long way to you know, addressing one of those drivers of mental ill health. Other issues, of course, are around discrimination, and that's within the justice system itself. It's within employment. It exists within our, you know, parliament, as we know. So that is really something that if we were able to really look outside of the system and address those drivers through prevention, would be fantastic. How confident am I? I think it's long-term change. We're not really going to see that change for many years and probably generations. So I am optimistic that change will happen. We've got some fantastic primary prevention programs. We have our leadership, at least at the state level in Victoria, is very supportive of gender equality and preventing violence against women. We need more ongoing long-term resources in that work so that we can generate long-term change. So yes, hopeful, but I don't think it's anything we're going to see in the short term.
And this is an interesting question. And this person's asking, how do we ensure that, or how can we ensure as much as possible that services are non-judgmental and also combat stereotypes and racist views that might exist about migrant families? Because I know I was involved with a women's health summit that the Royal College of Obstetricians and Gynecologists ran in Canberra a couple of months ago. Seems a long time ago now, when you can all meet together and get together, but it was really good. And one thing that I really remember from that day was a woman who was representing migrant women who was talking about the sort of inherent biases when migrant women go to seek medical care. that she feels that was something that a lot of migrant women do feel like, that there are a lot of assumed assumptions when a migrant woman does go and seek healthcare. How do we overcome that as much as possible, or ensure that at least it's acknowledged and aimed to be addressed as much as possible?
Yeah, Sophie, I completely agree that that's a big issue. I think that there's the stereotype that, say, if a migrant woman does present with some mental health concerns to a health service, there might be a stereotype that there's something about her culture that's creating that, or that, she's in some way implicated in that because she's not willing to kind of reject her culture. So she's agreeing then to,
Yes.
harm herself, essentially. So I think that is a really important factor in redesigning and training up really health practitioners to better understand that when you have a person in front of you, they're a whole person. And there are going to be a whole range of factors impacting on them. Culture might be one of them, but you've also got gender, and you've also got life experience, settlement stress. You've also got discrimination that she's, as well as sitting in your office getting discriminated against, potentially. There are other experiences of discrimination they might have just experienced it on the train getting there. So there are a whole range of factors that intersect with culture to create the person and, contribute to their potential mental health concerns. And they're all going to be not only a part of what might be causing that woman to be sitting in a doctor's office, they're all also going to be part of the solution. So addressing some of those issues, it could be that that woman's culture is a strength, and that's what's going to really help her get the support that she needs or change her life situation so that she can move beyond whatever issues she's having. So yeah, definitely need not only better training for health practitioners, but also, I guess, more broadly in the community, a better understanding of culture and what it means for migrant communities, and so that we combat those stereotypes much more broadly in the community, so that by the time you're sitting in the doctor's office, the doctor's less likely to be drawing on them for their work.
Yes, and it's something that everybody needs to think about, not just the two people in that room.
Yeah.
So we're almost out of time, but is there only one last thought you'd like to leave the audience with, particularly on this issue about intersectionality, and as we move forward with the sort of exciting process of creating these new models of care?
Yeah, look, there's one thing that I think we often think about, a health service kind of sitting a little bit separate to the community, and that the role of the health service, if it's going to be responsive, is to engage the community. But I think one way that we can think a little bit differently about that is to think about the health service as being a part of the community and the community being a part of the health service, so that they're not separate and distinct aspects, but they're, both actually working together, integrated, and that's the way that health service sits within the community to move its concerns further. So if we can get beyond kind of, thinking about the big bureaucracy of health and the system, to think about it as being a way that a community can, resolve its own health, whether they are health problems or whether they are ways of generating more good mental health in the community, that the health service can be a part of that solution for the community.
That's great. Look, thank you so much for your time. That's absolutely flown, that session. It was really interesting. I'm sure we could keep chatting for a lot longer, but we've got a packed program we need to get through. So thank you so much, Dr. Murdolo, for your time today, and keep up your amazing work that you're doing for women in Victoria and Australia, and it's such an important role that you have. I'm sure it's been absolutely fantastic to have you as part of today's session. So thank you very much.
Thank you, Sophie. It was such a pleasure to be here.
Big virtual round of applause, everybody. Thank you so much. Okay, we've got a packed session before lunch. So we've got a couple more things we need to get to. So our next session is what we're calling the showcase series. If you were with us last week, this is where we hear from people who are out in the community doing amazing work in the mental health space. And these two sessions we're going to hear from is all about incorporating lived experience into the work that's being done. And we're going to hear from Belinda Caldwell, who's the CEO of Eating Disorders Victoria. And then we're going to hear from Rose Cuff, who's the Executive Director of the Satellite Foundation, and about the great work that both these organisations are doing, and with a particular focus on incorporating lived experience. So I will hand over to Belinda. Welcome.
Thank you. So I'll just get my screen. Oh, it's saying I can't share my screen. Tech.
That's all right. There we go. Just give us a few minutes.
Yeah, that's all right. Got it.
There we go. It looks like we're
there.
We're just in black at the moment, but it'll probably just take a couple of minutes. But here we go. Yep, that's all good. You're all up and running.
Fantastic. So thank you everybody for having me today. Yeah, I'm talking about our journey, I guess, with incorporating lived experience at Eating Disorders Victoria. Just want to acknowledge the traditional owners of the land on which we all meet today. At EDV, we acknowledge the traditional owners on which our office is located, the Boonwurrung and Wurundjeri peoples of the Kulin Nation, and pay respect to their elders past, present and emerging. And we always also acknowledge the lived experience of eating disorders and other mental health experiences that may be present today. So Eating Disorders Victoria, if people don't know who we are a sort of the leading community organisation helping Victorians to understand and recover from eating disorders. We see ourselves as a trusted source of support since we've been around since 1983, and we provide a broad range of free and low-cost community services that respond across the breadth of eating disorder experience, from discovery of an eating disorder through to recovery. And then there's a whole lot of our services, but people can go onto our website if you'd like to find out more about what we do. So at EDV, really everything we do is informed by lived experience. Lived experience is welcomed in all our staff, not just peer workers, and we provide optional lived experience supervision group, so monthly, and really the people who are involved in peer work, but also the admin officer who may have their own lived experience of an eating disorder are all welcome to join and do join that supervision group. We have wellness plans for our staff members, and just in general, EDV is a very safe space to talk about lived experience. I have my own lived experience of caring for my daughter with an eating disorder, and the majority of our board have lived experience as well as really important board skills and experience. So currently about 70% of our staff have lived experience of an eating disorder. We also really value listening to our community and their lived experience. So we have a lived experience subscriber group where people can put their hands up to be contacted when we get asked for lived experience views for submissions, but also, if we're just trying to test ideas and thoughts, we use that group. We get feedback on closure of all of our cases or any sort of episodes of support or engagement with anyone within our community. Once that sort of engagement is closed on our CRM, we send out a feedback form, and so we get constant feedback coming in from everybody that accesses our services. We have a community survey, and we're increasingly moving towards much more structured co-design. So we have a project which we're in the middle of development at the moment around supporting people with severe and enduring eating disorders, and we're really taking much more of a co-design approach, a structured co-design approach to the setup of that program. We really see our role at EDV as that of being a trusted guide for our community, and part of that trusted guide really comes from the lived experience that's embedded in the organisation. And we have particular programs that really leverage off lived experience in a more strategic way. So one of these, probably our most mature program, is something called the Peer Mentoring Program. It is where someone who has recovered, so matches a recovered mentor with a mentee. We call them participants in our program, and I think that's quite important across a range of our programs, that people don't like client or consumer or mentee. They really value the term participant. So I'll refer to participants as we go through. And this relationship, or this match that occurs, then goes on for 6 months, 3 hours a fortnight. And every 2 months there's also a participant group session, and then after they finish there's an alumni group. At the beginning of the 6 months, the mentor and the participant come together and develop a wellness recovery plan, and that's where the participant really sets their objectives about what they want to achieve over the 6 months. And then when they get together, mostly been virtual for the last 18 months, but they do a range of activities. Lots of arts and crafts happen often. Those arts and crafts, I don't know if you can see the pictures very clearly, but at the top there's worry dolls. So one one pair or whatever made worry dolls, but you know, that time is talking about how they manage their anxiety and how did the mentor experience anxiety and what they were doing. So but they kind of focus on an activity while they're having their chat. Quite often there's cooking. We have a kitchen at EDV, so we'll find our peer mentor couples in the kitchen, cooking up a storm, supporting people to really do cooking of, you know, really focusing on really great nourishing food. Eating out is often something that's really anxiety provoking for our community, so you'll often find them down at the local coffee shop, but also it can be things like galleries, going to art galleries, going for a walk. We had an evaluation done on the first 2 years of the program, and we had an economic evaluation done as well, and found that we reduced hospital readmissions by 75%. In 2017-18, the program was 20 matches a year, and the current year that we're in at 70 matches a year. So it's been growing significantly over the time. And how we manage that, we have really strong training. All the mentors have a very structured training program. We then have mentor supervision, and that's one-on-one. So after every session that's held with their participant, they have a one-on-one chat. And we've actually, because it's grown, the people that are doing the debriefing are actually what we call peer mentor leads. So they have been peer mentors, and now they're the leads, and they're doing the one-on-one supervision. And they also have group supervision every 2 months. As I said, that we do debriefing, but we also do quite a lot of monitoring of the program. So we've been testing, you know, really from the first day, whether people's quality of life, depression, anxiety scales and eating disorder symptoms are going up or down over the life of the program. And we actually were monitoring. We've just stopped because we've actually found over the life of the program that there had not been any adverse effects on our mentors. But we were in the early days of the program monitoring their eating disorder symptoms as well. We also use lived experience as a trusted guide in our Stories of Recovery program. Really, this is sort of safe storytelling to groups. We provide people who go out and tell their story of recovery in inpatient programs, day programs, community group education, health professional education, and carer groups. We also have an increasing demand, particularly just recently, for co-design participants. So we provide those for services and then we support those participants. With all of these, there's a whole training program that's involved and then debriefing that's provided after any particular event. We also use lived experience as a trusted guide through our support groups. So particularly since July last year, we used to have 3 face-to-face support groups that were offered, but through the COVID funding, but also just the demand, we moved to online support groups, and we moved to all of those support groups being facilitated by lived experience facilitators. So we have all these different groups. We have REACH, which is for people with restrictive eating disorders, Beyond, which is for people with binge eating type eating disorders, Cosmo for those with sort of co-occurring disorders, Bloom for our LGBTIQ plus community who are very adversely affected by eating disorders, Viva for people living in a larger body with an eating disorder, and Rally, which is our support group for carers. And again, training and debriefing is provided. And the final program I just want to talk about, it's a new program, but it's quite exciting, where we're using carers who have had lived experience of supporting their young person with an eating disorder to be carer coaches. So this program has been specifically come out of the COVID demand, where we've seen a dramatic increase in young people with newly diagnosed restrictive eating disorders, and our service system really struggling with it, and there being very long waiting lists. We developed this program for families of young people with newly diagnosed restrictive eating disorder who are on a waiting list, and they need to be medically monitored to participate in the program. And our carer coaches provide one-on-one coaching sessions once a week over 8 weeks, and there's structured psychoed. The program is a mix of structured psychoed plus individualised coaching and support. It's really designed to activate families to arrest weight loss, commence renourishment, and interrupt compensatory behaviours, all of which are keys to the treatment that they will be offered once they get off the waiting list and into treatment, which in our public mental health system is family-based treatment for under 18s. As I said before, the carer coaches have their own lived experience of not only caring for someone with an eating disorder, but undertaking this particular treatment model. And the early data really excitingly suggests we're comparing very favourably to the early stages of treatment. So every family bar one has been able to arrest weight loss, and approximately half have been able to renourish their young person and get some weight gain happening. So we're pretty excited about this particular program. What we've learned is training and support is critical, but it's about managing the risk, not avoiding the risk. We really have a culture of not tiptoeing around lived experience. There's so many of us with lived experience in there. It's it's also a way of showing respect for lived experience. We don't need to be treated differently or tiptoed around. Creating a really safe environment. So in particular for us, our workspace is a diet talk free zone. So we have particular things that we undertake within our workspace that make it a safe environment. We're very into sort of strategic use of lived experience. It's not just about, there's an element of, we get you and support, but that we can actually use lived experience in a really tailored and purposeful way to make a difference. And really it's just about building it into the overall culture at EDV, sharing of experiences, respect for each other's experiences, and really lived experience sits in the suite of valuable skill sets that everybody's bringing to the table. And if anybody wants to see anything more about EDV, there's all our connections and our contact details. And I think I've finished.
Thank you so much, Belinda. That was a great presentation. Lots of amazing detail there, and such a wonderful use of lived experience in just so many ways. And I really appreciate all the work that you're doing. I've done a lot of stories on eating disorders, and I know how prevalent it is. I know how it's been a big issue in the pandemic. So it's great that you can give us a really good update on what's happening with the great work that you're doing. And as I mentioned earlier, everyone in the audience will get all these slides, because there's lots of great detail there and all your contacts. I'm sure people will want to get in contact. So thank you very much for today. We really appreciate your time.
Thank you.
We're now going to move to our next showcase presenter. Rose Cuff is the Executive Director of the Satellite Foundation. And I only just became aware of the Satellite Foundation not that long ago, actually. I got to know them through Instagram. They've got a great Instagram account where they showcase the great work they're doing for, which you'll hear about when Rose talks about what they're doing for kids who are carers with someone in their family has a mental health struggle. So really looking forward to this session from Rose. Here she is.
Hi.
Hi, Rose. So look, thank you so much for presenting to us today. I'll hand it over to you.
Oh, fine. Thank you very much, Sophie, and everyone can see me, hopefully. Yes, thank you. And thank you for inviting me to discuss today some of the approaches that we are developing to integrate opportunities for the young people that come into our community to be peer leaders and facilitators at Satellite, which is what I'll be focusing on today. I'd like to start by acknowledging the traditional custodians of the lands that we're meeting on today. I'm on the lands of the Wurundjeri people of the Kulin Nation, and pay my respects to elders past, present and emerging, and also pay my respect to any Aboriginal or Torres Strait Islander people in the room, and also acknowledge that sovereignty was never ceded. I'd also like to thank the Victorian government for their support and funding at this stage. So I've opened with this photo of this group of amazing young people who were the first graduates last year of our first 2 online Satellite Connect programs. You might be able to tell this is actually not a Zoom photo. Well, it isn't a Zoom photo. It was actually at a retreat we held, which was amazing in the lovely Anglesey. So they're sort of some of the first graduates of our program, and I'll talk about in a minute. And I wanted to put the photo first because they really are the voices that I invite you to hear and the voices that guide us. Very important. Just a couple of words about Satellite, and thank you, Sophie, for the introduction. Satellite is a non-profit community-based organisation. We're based in Victoria. We offer a range of peer support programs, both, of course, online and in person where possible, from the ages of 8 to 25, very approximately, because we recognise that developmentally it's different for every single young person. Fundamental to our work are the principles of utilising a very wide range of creative platforms to facilitate the kind of connections and conversations about mental health and well-being that we think are so important, to facilitate peer support and sustaining those connections. They also help to integrate the voices of young people into everything that we do. And as we grow our organisation more recently, we're really focused on strengthening our co-design approaches and our frameworks. Next slide, please.
Are we able to just move through the next slide for Rose? There we go.
Thank you. So I've got to get so this is a picture of some T-shirts with our sort of 3 mottos, just which are stay connected, be creative and keep well. And they're, again, the sort of pillars that we weave into the work that we do with young people. We take a very broad view of mental health and well-being. We use what we call a light touch approach in our conversations with young people, parents and carers and family members. And we do a lot of work, particularly with a younger age group of children with their families, whether that's their birth family or the family that their family of choice, or they might be in out-of-home care. So it's very broad. Any young person can participate in one of our programs, and if they're under 18, that's as long as their parent or carer or primary supporter acknowledges they are experiencing mental health challenges in some way. This is for consent purposes. But for the purpose of this brief presentation, I'm just going to briefly describe the pathways in which a young person can move from participating in a program to taking on roles of either a peer leader or a peer facilitator or more. Next slide, please. So as we moved through 2020, we kind of got through 2020 and the need to transition our core program, which is called Satellite Connect, which is basically has become an online 6-week program featuring 6 2-hour workshops. We really listened to the young people that you saw in that early photo coming through that, and their wish to develop their skills, their knowledge, their confidence to work alongside us and each other, and also externally to sort of find out more about what was happening in the world of peer support, peer work, and youth advocacy. We also see them as the holders of wisdom. They inspire us and as people with enormous strengths. We also see these peer leadership spaces as very important opportunities for young people to connect, to reconnect, to keep reconnecting, and to celebrate who they are. So at the beginning of 2020, we employed a young person with lived experience of having a parent with a mental illness and a graduate of our programs to really consolidate this thinking with us and co-design this still really developing program called Youth Pathways. And as you can see from the slide, there are 3 arms to the program. The first one is called Learning and Development. And the Learning and Development part of Youth Pathways is the curation of a series of workshops, and they're topic-focused workshops. So far, we've run workshops all online, including being work and year ready during the pandemic, a wellness workshop, an online training called Facilitating Care, which is around program facilitation, Public Speaking 101, which was facilitated by one of our ambassadors, Brad McEwen. We ran a spring healing workshop actually last night, which was really a beautiful celebration of spring, but also how we can attend to our self-care and our self-nurturing, both for ourselves and the people around us. And we're running a peer leadership in online spaces one in October. So that's the learning and development part. The second arm is sharing your knowledge. And these are ongoing opportunities for these young people to participate in a whole range of opportunities, including consultations, working with us on our co-design framework, providing advocacy. There's a range of, and public speaking, a couple have done some public speaking, and the ways that we can provide support for those roles. The third arm is peer leading and facilitation. And this has meant that we've been able to move some young people through from a program graduate into, and I'll come to that in a minute and give an example of one young person, in training and supporting and equipping them to be peer leaders, for example, on a camp with young children. We have a program called At Home with Satellite, which is starting next week, which is for younger children, and following up that training with one-on-one support. Next slide, please. So I'd like to just introduce you to Ree to sort of illustrate how our peer leader and facilitator kind of emerging model has played out for her. She's quite amazing. In only 12 months, Ree has journeyed with us from participating in Satellite Connect in October, so almost a year ago, to actively seeking out and taking on peer leader roles on the camp, which we did do a camp in April with 2 camps back to back, actually, with 45 kids, an at-home program as a peer leader, and soon she'll be the peer facilitator in our Satellite Connect youth program, which starts on October the 13th. And Ree's talked at length about these experiences being really strong contributor to her gaining confidence and capacity to practice self-care and self-compassion. And we're very grateful to her for being in this space. It's been quite a remarkable journey to witness. And I asked her before doing this presentation if it was okay to sort of feature her. And she just said that the program and the peer leadership roles have really helped her and inspired her to be the best version of herself. And she's now doing, as you can see, a Cert 4 in mental health peer work. So we want young people coming into Satellite to see that the program is kind of the beginning, if they want. It's a beginning of lots of other things they can take part in. Next slide, please. So just to sort of finish up with this idea of staying connected is incredibly important for us at Satellite, because again, we've, particularly in the last 18 months, this idea of finding innovative ways to stay connected, both us with them and them with each other. And we continue to be challenged by that, about how in the online space we can offer these opportunities so that they're vibrant and they're engaging and they really honour what young people want. This is Tommy on the left, and he's also a graduate from Satellite Connect, and he's going to be a peer leader in a schools pilot that we're doing next month. It'll be a 6-week, it'll have to be online program in a high school in Melbourne. So just in sort of summary, the approaches that we are exploring are really still being developed. Satellites is a young player in this field, and I really have huge respect for people and organisations who've been working on models of peer support and the peer workforce for a long time, and we're drawing on those ideas a lot. So we're still developing our own way and sort of finding our way of doing it that honours our particular way of working with young people. We'll be recruiting to the youth coordinator role, which is very exciting, in the next month. And that'll be a young person with lived experience. And we already have somebody in the role of the youth advisor who's also come through our programs to assist with that role and support the establishment of our youth voice advisory group. We're really strengthening our focus at the moment on the provision of supervision, care and support to these young people taking on these kinds of roles, both within Satellite and increasingly as they venture out and do more externally to us. And we want to make sure that we have the strong procedures in place to make sure, for example, they're properly remunerated and ongoingly supported. It's a really exciting time for us, exciting for us to be able to keep going to the young people that have come through our programs in only a year, really, and just I'm constantly in awe of their ideas and their strengths and their commitment to transforming the system, really. And we're keen to keep building these relationships, but also with the people probably watching this presentation, organisations doing incredible work, and to share our experiences beyond our satellite orbit. I didn't actually put up that's my last slide. I didn't put up the contact details, but the website, which is about to go live with new, but it's still there, has all our contact details on it. There's a phone number, there's a website, there's how you can register for a program, etc., etc. And also we're very active on social media, so feel free to follow us on Instagram or Facebook. And thank you again.
Oh, look, thank you, Rose. And yes, if you want to jump onto Instagram and definitely follow Satellite, they put up lots of great content there, and that also will have their contacts for the website, which sounds fantastic. And that was a really great explanation of the work that you're doing and showing how you're really helping young people have a voice, such an important platform for them to have a voice and incorporate the lived experience into everything you do. So thank you, Rose, and it's been great to get to know you in the Satellite Foundation. So we really appreciate you taking time to talk to us today. So thank you. And we're going to move on to, we've got one more one more important thing before we break for lunch. We are delighted to be able to introduce Kieran Halloran. He's going to be releasing some important research into mental health recovery and the NDIS workforce. Now, Kieran has worked with Mental Health Victoria for the last 12 months, and he will introduce the team from Trobe University.
Look, I'm very pleased that Mental Health Victoria has offered the time in the symposium series to formally launch 2 significant reports which detail the importance of building good recovery-oriented psychosocial practice and services within the National Disability Insurance Scheme. And in previous times, we might have held a session at a conference to profile this work. For those of you who don't know, conferences were events where we travelled outside of our 5K zone, and we met in large rooms where we drank really bad coffee and talked face to face. So let's hope we have those times again soon, and we don't have to get lost in the in Zoom black holes. So briefly, I just really want to explain the project and then hand over to Lisa and Katherine to really talk in more detail about the research. So really, an MHV project team, which includes Anthea, Steph, Louise and myself, are delivering a national project funded by the Department of Social Services, the Federal Department of Social Services. And I also want to highlight the contribution from members of our project reference group with whom there have been significant consultations, feedback and input. So you can start moving through the slides now as I speak. That's great. These sector experts have added greatly to our approach and work. So with the next slide, it's really just our project aims. Very briefly, the project aims to build a national picture of workforce activity related to the NDIS psychosocial services and to improve the capacity of the NDIS providers to deliver recovery-focused support. And I note that this morning, Katherine highlighted workforce capability and capacity issues related to the Victorian reforms. And last week, Pat McGorry also highlighted this in his presentation. And we hope that this work, while focused on current NDIS issues, has many transferable elements to the Victorian reforms and workforce development needs that will continue to arise. So just one more slide briefly about the project. What we're hoping to do to achieve all the goals of the project is to design a national information exchange site. We're calling it a digital hub, providing access to professional development, information and resources related to recovery-oriented psychosocial disability support. We want to develop good practice guides, which will detail better approaches to recovery practice. And we want to trial and inform training nationally. And through, among other approaches, we want to trial some online micro training, which seems to really meet the needs of a very diverse workforce. And we want to influence possible improvements to the national vocational education and training sector, the VET sector, regarding pre-vocational training for future NDIS workforces. So the next slide really, as a foundation to this work, we acknowledge that the project required a contemporary evidence base for recovery-oriented practice. And to this end, we commissioned Trobe University, led by Professor Lisa Brophy. And the Trobe team have worked very closely with the MHV project team. It's been very collaborative work. And we're really pleased to have Professor Brophy and Dr. Brazier available today to discuss their work in some detail. And I'll now hand over to Lisa and Katherine to present, and then I'll say a few words at the end. So thanks, Lisa, take it away.
Thank you so much, Kieran. And if we just go to the next slide, we're delighted to just introduce our project team. So myself, Professor Ellie Fossey from Monash University, Katherine, who's about to speak to you, and Megan Jarks and Nina Whittles, who both contributed as research assistants for this project. So I'm very delighted to be here to launch our stage 1 and 2 reports, the current landscape and the future horizon. And if we go to the next slide, I might hand over to Katherine.
Thanks, Lisa, and thanks, Kieran. It's been lovely being a part of this project, and it's an important project because it is linking our recovery orientated practice to what could be good practice for NDIS workers in the future. So we have currently completed the first 2 stages or first 2 reports as a part of this project. The first one in stage 1 was a literature review on recovery orientated practice, including on key populations, psychosocial disability in the NDIS in the context with that. We also had a look at enablers and barriers that we knew around recovery orientated practice and disability support. The stage 2 report built on these findings, and we synthesised a group of leading frameworks in reference to this as well. We looked at examples of innovative practice and training, and we started to explore ideas around capacity and capability building. Slide, please. So here we can see, I'm sure, concepts that many of us are familiar with, and this is what came out of our original literature review. It was reinforced by findings from consultation and our own expertise, the team as well. And it starts to think about recovery orientated practice as being comprised of a number of components. So some of the important components that we identified included things like things being person-centered and trauma-informed, looking at it in terms of being social and relational, so not just about physical functioning. And we started to as well look at things like lived experience and the possible role of how that could assist in recovery-orientated practice, and then I guess be applied within an NDIS context. We also identified a couple of contemporary models where recovery-orientated practice had been implemented with Refocus and Pulsar. And I think that we will talk about more how these elements build an impact on recovery-orientated practice, potentially for NDIS as we go along. And I think, Lisa, I think it's your slide next.
I think we're talking about the leading enablers, the next slide.
Yep.
So what we saw as the leading enablers were we saw the lived experience workforce really being critical to enhancing recovery-orientated practice in the NDIS. And here are some other examples as well of being responsive to trauma, having skills in collaboration and communication, being critically aware of human rights and social determinants. We identified cultural safety, the inclusion of families and carers as being critical to recovery-orientated practice. There's also that expectation that people will be able to engage with sector navigation. And a really important finding is that recovery-orientated practice starts at the top. We need organisations that are well prepared to support people to undertake recovery-orientated practice. And some of that relies also on supervision and training. Thank you. To the next slide. So this diagram describes the key intersecting elements of recovery-orientated practice as we've identified them, conceptualised as foundational, building capacity and promoting recovery, but also recognising that recovery-orientated practice, like personal recovery itself, is not linear or hierarchical. Recovery-orientated practice offers multiple opportunities for the NDIS sector in relation to people with psychosocial disability. Notably, recovery-orientated practice can enhance relationships, community participation and choice and control, which can have significant impact on the experience of participants and support people in building their capacity as they work towards meeting their goals and aspirations. Next slide, please. So the Stage 2 report presents the workforce capabilities that will contribute to recovery-orientated practice. And these intersecting workforce capability domains emerge from existing frameworks, the Stage 1 recovery literature review that we undertook, as well as a series of consultations our teams, my team conducted with our project reference group and other experts, including people with lived experience. And the frameworks were from both disability and the mental health sector. And those resources were chosen because they were realistic and feasible, as well as aligned with recovery-orientated practice. So if we could just go to the next slide, please. So the Stage 2 report identifies the organisational sector and systems issues that impact on recovery-orientated practice as well. And key resources for this section emerge from the National Productivity Commission, the Victorian Royal Commission into our mental health system, NDIS policy, other government documents, and change management literature. And as with the workforce capabilities, we were informed by frameworks from the disability and mental health sector, those stage 1 learnings that I spoke about, especially barriers and enablers for practice, and literature describing recovery-orientated practice implementation and training in organisations nationally and internationally. And you can see, as with the workforce capabilities, we've moved these into 4 thematic domains. So looking at systems and processes, values and culture, quality improvement, networks and community. And additional elements discussed in this section of the report include the range of providers in the NDIS and how that impacts on organisational capabilities and building workforce capacity, the importance of building networks and opportunities for providers, and of course, the need for future research and evaluation. So next slide, please. So we're really hopeful that these 2 reports are actually going to provide a foundation for change, both in the short term, the medium term and the long term. And in the short term, we looked at the idea of the reports provide a foundation for future guidelines, training, being engaged in more opportunities for co-design. We particularly felt that the peer workforce development was an area of need. Leadership and culture change is also going to be important in the short term. In the medium term, standards, credentialing, training programs, a supported workforce, including supervision and mentoring. And what also emerged was the value of communities of practice. So people getting together to talk about undertaking recovery-orientated practice and learning from each other. And in the long term, we can aspire towards co-designed and co-produced organisations, accreditation, expanded training to all of the NDIS workforce, and even maybe the introduction of a personal recovery tick from an approved regulatory authority for organisations who really want to make a claim that they engage in recovery-orientated practice. So I think we're on to the next slide and back to Kieran.
Well, thanks again, Lisa and Katherine. That was fantastic. And once again, we're really pleased to be formally releasing our first and second stage reports, the current landscape and the future horizon. The Trobe and MHV teams are continuing to work together on a third stage report. And this report will incorporate the co-design feedback developed within the project. And as Craig noted earlier, we are really concerned that we make this as authentic a co-design approach as possible. We want to include a very deep analysis of participant and family experiences of receiving recovery-oriented supports in the NDIS, and likewise include the experiences of workers and providers who are delivering or trying to deliver effective psychosocial supports. To this end, we've conducted over 30 workshops and focus groups and consultations across every state and territory, and this has been no mean feat in COVID times. Running a national project in lockdown is a challenge. It's kind of a bit of a tautology, really. But thanks to the team for their persistence and positivity in making it happen. We've met over 250 current NDIS participants, carers, family members, and people and workers and providers of psychosocial services. And in these meetings, we've tested the evidence base in these reports. What resonates most with current service users? How do service users and workers describe recovery enablers, and how do they identify what is needed to improve the services and supports? This co-design approach will then be applied to the research evidence base, and out of this, we plan to develop the third stage report. This will also allow us to discuss and make recommendations regarding the possibilities for improvement of the future service delivery within the NDIS, but we hope these learnings can be extrapolated to all mental health workforces. We hope to have this final report ready to be released before the end of the year. So thanks to all participants, families and stakeholders involved in this important work. And to read and download the reports, you can head to the MHV web pages.
Welcome back, everybody. Hope you had a nice lunch break. Now we're going to get straight back into our first session for this afternoon. And this session is looking at the issue of providing crisis support. And we are going to be doing a word cloud. So everyone, it was fantastic to have your input for the previous sessions, doing the word clouds again. So I'm going to introduce the panel first, and then we'll go to a word cloud. We've got a great panel for this session. I'd like to introduce, we have Wayne Gatt, who's the Secretary of the Police Association of Victoria. We're going to be hearing from Associate Professor Mick Stevenson, the CEO of Ambulance Victoria, Tom Dalton, who's the CEO of NEMI, I hope I'm pronouncing that correctly, and Fran Timmins, who's the Director of Nursing at St Vincent's Mental Health, and she's also one of the leading advocates behind the Safe Haven cafes at St Vincent's as well, which is fantastic. So we've got Wayne, Fran, Tom, and we're just waiting on Mick to pop up as well. But while we do that, why don't we just jump onto Menti? If everyone can jump onto the menti.com website, and you've got the code. Let me just grab it as well. The code is 427-03529. And so you can pop the question we want you to address with this word cloud is, what are the biggest barriers to effective crisis response? And if you want to just have a look at that, we'll put, while we're waiting for Mick just to turn his camera on. And then once that happens, we can go to the word cloud, have a look and see what people say. And I'll jump on the Menti site as well. Let me just grab it. There it is. So yeah, it's been really good. And thank you everyone in the panel for being part of today's session. Oh, here we go. We've got Mick now. Excellent. Thank you. So let me just log into Menti as well, so I can get what everyone's saying. Sorry, 427-03529. Excellent. Okay, well we might just pop over now to, we've got Wayne, Fran, Tom and Mick. Everyone's on board. That's excellent. So while we wait for the word cloud to pop up, I might just go to the panel and get your views as well. When it comes to providing effective crisis support, oh, here we are. Here it's coming up as well already. So that's great. So the way the word cloud works, just to remind everybody, is that the more people that put in a certain word, the bigger the word pops up. So you can see compassion, training. There's some of the overly complex systems. So let's go through, let's just reflect from the panel what they think, and then we'll go into some other points that we talked about when we had the discussion previously. So maybe we'll start with Mick. What do you think of what are some of the biggest barriers when it comes to providing effective crisis support in the mental health space?
Yeah, thanks very much, Sophie, and thanks for having me today. I hope you can hear me okay.
Yes.
I think I got introduced as the CEO of Ambulance Victoria. I'm actually the Executive Director of Clinical Operations, so
I'll give it a few promotions today, actually.
Very nice, Sophie. I don't think Tony needs to be deposed. I'm more than happy to.
That's
be
right.
here.
I do know Tony as well. Maybe it was my conflating the two things. So
that's the haircut,
thanks
Sophie.
for that,
I think. So just, I think, from our point of view in ambulance, the thing that we see in mental health and effective crisis response is the lack of a coordinated system. And I'll just draw the analogy to something like the trauma system in Victoria, which is regarded as the preeminent trauma system in the world with the best trauma mortality and morbidity in the world. It works because it's an end-to-end system. It works because the state convenes the system, it's ministerially supported, and every part of that system links into the next based on protocol, guidelines, algorithms, and there's an effective measurement system that's applied over that. So the quality assurance system that links into that assures that the system works. And so it's end-to-end from training and development of staff in that system right through clinical care and quality assurance. So the end-to-end system works. We don't see that in mental health crises. What we see is disparate parts of the system doing what they do best, trying to make best of what they've got without actually being formally linked. And I think if there's one thing that impedes us in the work that we do, it is that lack of an integrated system.
Yeah, good point. And Fran, I might just go to you now, and you can see one of the words that has come up on the screen from the audience point of view is that they see that stigma is one of the biggest barriers to effective crisis response. What's your reaction to that?
Absolutely. I agree 100%. I think in setting up the Safe Haven Cafe, one of the things that I learnt from our process, our co-design process, co-production process, and since the services operated, is that a clinician's definition of crisis varies differently to what everyone else's definition of crisis is. And I would challenge everyone to Google the word crisis, and you come up with there's a health definition on there. I won't say from which health service, not Victorian, but there is one that says that it's a disruption or breakdown in a person's family's normal or usual pattern of functioning. A crisis cannot be resolved by a person's customary problem-solving resources and skills, and it may be different from a problem or an emergency. And I kind of think that's hope. That doesn't inspire hope in anyone that they can get through. We all have crises all of the time, weekly, daily, monthly. What I've learned is that people come to our cafe in a crisis, and it's not the crisis that we expect them to. And they come to us expecting us to treat them the way that health services and others do treat them. And we do need to acknowledge that stigma is not gone away at all. Even in this time of pandemic, when we've all learnt a new definition of what loneliness is because we suddenly feel it.
So you're just breaking up there a little bit, Fran. So I might move on. No, you're fine. So I might move on to Tom, maybe just to reflect on one of the other words that have come up there, which is compassion. How important is that?
Look, Sophie, I think that this is critical, and I think interesting. It links back to both what Fran and Mick are saying, because we know that if we're going to effectively respond to mental health crises, we need to be demonstrating compassion. We need to have a specially trained workforce that understands the needs of the people who are going to front up in this situation. And we need to have alternative models. And I think, just picking up on some of Mick's comments, the point he made this morning, just then, was similar to what he was making last week when we were preparing for this, that there isn't a system. And at the moment, we only have really one or two responses and some helplines that are poorly coordinated. If we're going to shift the way we respond, we need to be giving people different options. And I mean, my thinking on this has really significantly changed in the last 6 months since NEMI, in partnership with the South Australian government, set up the Urgent Mental Health Crisis Centre in the centre of Adelaide, which is a step along the continuum from the Safe Haven cafes that Fran's talking about, where you've got 18 crisis chairs there. It's taking responses for all but the most serious categories of need directly from the police, from ambulance, and but it's a different option. And the thing that we know is if you're going to make that successful, you need to train your workforce. You need to be really thinking about those issues around stigma and compassion, and bringing them into both a different model of care, and a different approach that really puts a huge emphasis on that. And we know from the work we do, one of the keys to that is by having peers, by having people with lived experience working in those services. And it also goes back to the point Fran made in her learnings, that you need to do a lot of co-design and thinking and listening to the people whom you're trying to engage in thinking about how you build up these systems. They're not easy to do, but they can be done.
So talking about building up systems, so before I go to you, Wayne, I'm going to, I think we've covered a fair bit about what was in this word cloud. And so I think I'm going to move on to what we talked about when we were preparing for this session. And this is what we want to talk about in this discussion is what kinds of interventions do these community-based services need to deliver to prevent people ending up in a crisis situation? So I'll go to you, Wayne. We talked about this the other day, and also for the audience as well, just to be having a think about if you have a question for our panel, please go over to Menti and pop it in on menti.com. But Wayne, so what do you think, what are the interventions that are needed to prevent people ending up in a crisis? And I might just get you to reflect on what you said the other day about what happens by the time the police get to a crisis situation.
Well, thanks, Sophie. And I think it goes to your word cloud. I know it's not on the screen at the moment, but the one word that wasn't there as a barrier is crisis. Crisis itself is the barrier that our members see. And the reality is, I know that my members in 2019, for example, went to 16,159 instances where they found people in a high degree of acute crisis. These are situations where it's gone terribly, terribly wrong. And to be honest, the area of last resort has been for somebody to ring 000 and call the police and the ambulance service together in more cases than not. It's a failure of the system to intervene prior to the crisis, to have community-based interventions when a person is in a better state to receive that care, that is compassionate care, that is supportive care, because there's a limited range of options that any of us in the system can provide a person when they're in such a heightened state or a high acuity state of crisis that we sadly see when we're called as a point of last resort.
Yes, I remember you saying that the police are generally called when things, well, I think you said something like when the wheels have fallen off, but when, you know, but it's because of what's happened in the proceeding. You were saying it's because of what's happened or what hasn't happened in terms of the care and support that people needed in the preceding days and weeks and months before you actually get to be called, or afterwards, that where the gaps really exist. And would you be hoping that that's where this new community model can be providing sort of good ongoing care for people, so ideally they don't end up needing to call you?
It's absolutely what needs to happen, Sophie. I mean, police will always have a role, as will ambulance, as will other first responders in terms of dealing with people in crisis. The reality is we also get told and we're also advised when the wheels are starting to fall off, when the indicators are out there, and sometimes it's not police that identify these issues. Sometimes it is. Sometimes they're people that walk into the front doors of a facility and ask for help, and they're met with a wall of silence or an inability in terms of resourcing to deal with that, turn back out into the community where the only thing they can do is support themselves. If we can intervene at that stage, that is the best chance of lessening the police reliance on lessening that crisis intervention and making sure that we have a support system, as Mick talks about, that actually wraps itself around people prior to them falling into a situation where they're really in a difficult position to support, no matter who you are and what you bring to the table.
Thanks, Wayne. And Tom, I might just get you to flesh out a little bit. You mentioned that NEMI is running this sort of crisis or community-based crisis response service, but can you just tell the audience how it's been going? It's been running for about 6 months, and some people in the audience may not be aware of it, but we just wanted to get a bit of feedback on how it's going.
Yeah, so and I think it is really timely in the sense that we're talking about different community models. And what happened when the federal government funded 8 PHNs around the country to deliver these adult mental health centres, or what have been called head to health centres, the South Australian government went its own way with that money and commissioned this urgent mental health centre. It started with a set of principles that were developed in an approach that was developed by the Lived Experience Network in Adelaide. And once we'd been selected as a provider, there was a huge amount of co-design that went on across all levels, across thinking about intake, thinking about service models. We approach this centre with an underpinning from our thought partners in it, who are called RI International. Many people would be familiar with RI International, an American not-for-profit that works in the mental health space, who operate a number of these centres throughout the states. But so we have a different model. It's peer first and peer last. So people with lived experience greet you on reception. We call it guests. And, you know, guests might come in, as I said, so at the moment, after 6 months, probably just under 25% come in via ambulance. And the first responders in the ambulance are really welcoming of this approach, because they know that it's a more effective way than sitting with people ramped up in, you know, waiting to get into EDs. But also 7% of our guests come accompanied by police. And it's been a really, you know, effective relationship. And in that co-design, we did a huge amount of work with police and the ambulance service about how we would take people, how we would meet them. We know that the ambulance response, well, the time the ambulance and the first responders spend at the urgent mental health centre is much shorter than were they to be going to the ED. And we know that, you know, one of the key drivers that bring people to the service is usually or most commonly suicidal thoughts. And so you know, we're talking crisis in all its forms. But you know, certainly after the first 3 months when we opened the centre to walk-ins, we've had 2/3 of our guests bring themselves there or come with family. And as I said, you know, the average length of time they spend there is about 3.5 hours, but that differs from person to person. And you know, it's a really different response, but it is staffed with clinical staff, and it has medical officers and psychiatrists and nurses as well. But the focus is on a peer-led response. So, you know, we've been really pleased with it. And I think, you know, going back to Mick's point, and the thought that we're commissioning these new community services, it needs to be done in a really coordinated way. There needs to be data from these services fed through in real time, so that we can understand from a policy point of view what's happening, and that we start to see mental health crisis response in a systemic way, not in an ad hoc way, where whether or not we know what happens to you, or when we know, depends on which agency funds you, you know, the local primary health network or the Victorian government or the Commonwealth through some other means. We really need to be looking at all these steps and different responses as part of the system.
Okay, thanks, Tom. That sounds fascinating. I'm sure lots of people in the audience will be really interested to hear everything you've just been saying. So I'll just move on to Mick now. So Mick, what do you think good care looks like for this group of patients? This is what we talked about the other day when we spoke as well. When the patients who are, or the consumers who are getting to the point of needing sort of a crisis intervention, or do we even know what good care looks like for that group of people?
Well, there's some common features about good care, and people that work in health will obviously understand them, Sophie. But you know, clearly, empathy for others is a very good starting point. And I think Wayne, you know, referred to the fact that that's not always present. So when you actually front for care, you don't often always get care, and so that's a really important position to remember. I think if those that have empathy for others do connect and are considerate, will then generally provide a good service. But it is, I'll take it back to the original point, it goes to the point of having end-to-end organised systematic care, where someone who enters that system should know what they're going to get. And at the moment, that varies considerably depending on where you go and who you're with. So it is about a level of consistency. It's about a level of expectation that the consumer can hold, such that they know what they're going to get in any given circumstance. It does require all of us to work together though, so, and it requires everyone in the system to share that empathy for others. And it's very difficult, of course, in mental health crises. They often repeat themselves. They're often incredibly difficult, situations to be involved in. They're complex emotionally. They can be complex physically. They can often be violent, and so it requires an extraordinary amount of skill. And I think in that sense, to think that people will enter, caring for people with mental health crises without the appropriate training, without the appropriate development, without the connection to a system that guides us through, every step, is really a really thoughtless and usually, develops a pretty fruitless response. So I think there's an enormous amount to be done in the sense that everyone in the system is connected. Everyone understands what's required of people with mental health crises, and that the system itself, links, connectedly, so that in a connected way, such that that patient, as I say, the patient knows where they are in that system at any given time.
Yes, and I think we talked about the other day about having those pathways of care and that are sort of known and accepted, and that people know that you will have follow up, and it's not something that just happens as a matter of chance, right? But it's sort of something that people will understand the pathway that they're being put on, and to make sure that they get the good quality care that they deserve. And I might just move on to Wayne. Would you expect, once these community mental health services are up and running, would you expect or hope that the police would be called out less, or do you think that the follow-up care, the community care, will come with you to ensure that people aren't left behind in terms of following up a crisis situation?
Well, I think it can be a combination of both, and we've always advocated on behalf of our members for joined up responses in crisis. So when you're talking at the critical end, it's about recognising the limitations of the policing service in that capacity. It's really to provide security to other first responders and the health system to do its work effectively. It's not to provide the healthcare itself. It's not designed to, and as Mick says, it's not trained to, and that's a very an empathetic response is relying on policing to do what it simply is incapable of doing. But I agree with you, it is about making sure that we intervene earlier to try and prevent. If you look back just 5 years ago, and you look back to say 2015, that's 16,000 cases we saw a year ago. Just in 2015 was only 9,500 cases. The acceleration of police attendance at the critical end is doing that one. It is skyrocketing at the moment. It's not just
whereas you'd hope it'd be the other trend.
We need to turn it back on its side and push it back down, roll it down the hill. And it is possible. It's just that we're seeing a system that is so under-resourced and so under strain that when you see the number of police interventions increase, what you're seeing is the rest of the system all blocked up, all under strain. And the best way of seeing that demonstrated is the number of police attendances that we are then called to respond to. That's more reflective of what's harder to measure, and that is the absence of capacity in the health system.
Yeah, and look, the ideal and the hope is that once these community mental health services are up and running, people will to get the help that they need there, and then they don't end up needing things at the crisis end. But we might just go, we've got quite a few audience questions coming in, so I might just ask Tom this question. The audience member's asking, how can family and supporters be better included during a crisis situation, including being informed and not excluded?
Yeah, look, that's a really good question. I mean, I think, again, for me, some of this comes back to what others have talked about. We need to make sure that we train people differently. We all talk about, you can say the big rhetoric, we need to change our approach, but we need to change the attitude of staff in some cases to how they engage with in the case of the UMHCC, where we call them guests or consumers, to be thinking about how family and friends or carers can provide those supports at the first juncture. Now, that's always got to be mediated by the wants and needs or choices of the consumer who's coming in the door. But I think we have to approach these things differently. We have to train our staff differently.
And we've got a few more questions coming in, so I'm going to try to get through as many as we can. And this is one for Wayne. They're asking, and I'm not sure what you probably will know more about this than I do. It says the program that's called PACER, PACER, has been evaluated as a cost saving for both VICPOL and health services, yet the service has stalled due to a lack of investment in the workforce. And the audience is keen to find out what you think of PACER. And maybe just explain to the audience who may not know what that program is.
It effectively lines up a mental health clinician with a police response. They sit in the same vehicle, they respond to people in crisis, and it's universally loved and advocated for by our members. Why? Because it puts that capacity into the seat of a police car that isn't there. It allows police to concentrate on their role and provides that empathetic response that we all want to be able to provide, but we're lacking. And yes, it is frustrating. We've seen this funded in some local government areas, in almost a trial capacity, to be quite honest. But over nearly a decade, it has proven to be a very, very successful way of dealing with people in crisis. It's been mirrored internationally, and indeed in different forms. You see co-response models, as they're commonly known, around the world. In the United States, in particular jurisdictions, leads in this response as well. And it really gives people time, space, and skill to deal with the situations that will invariably, no matter how good the system gets, we will always see people in crisis. I mean, that's just a reality of dealing with the mental health continuum. But it is recognising that when it does occur, that the policing response needs to be a nuanced one and an empathetic one, and that can only be done through these models. It's not cheap, it's not easy to fund, but it is so important, because without it, the outcomes can be very, very tragic.
Oh, that's good to hear. So, but it sounds like, well, this person's suggesting that there's that there needs to be more investment in the workforce for this program. So hopefully that will happen. Now we've got a question that might be a good one for Fran. I'll just go down to, where is it? It's talking about trauma. It says, considering the impact of trauma in the experience of crisis, how important is it to address intergenerational trauma and supporting young families? So how important is it that we recognise trauma, I guess, when people are in a crisis situation?
I think that the trauma response and those responses that come from previous experiences and cultural experiences play a big role in how a situation can deteriorate significantly. So for some people, arriving in an emergency department is a life-saving event. They come in, they've had a heart attack, they get some assistance, and you know, they think everything's wonderful. For a lot of people who have mental ill health, they arrive in an emergency department and they automatically have an automatic response, and they become more distressed, and there are less people there that have the skills and the time to be able to deal with that. And that all that does is compound the trauma for the next time. And I think that it's really easy for us, as a mental health clinician, it's easy, and someone who's worked in both PACER and ED mental health, it is really easy to forget that you're dealing with a human being when you have a system that rolls through. And so it is really important that you actually take the time to stop and think, and that's hard in an emergency situation. And it's why it's really important to have staff who are not only well trained, but have the right mindset when they're dealing with those front of house services. Really, really important, because they need to understand that people don't always voice their trauma. They show it, but they don't voice it. And that doesn't mean it doesn't exist.
Yeah, very good point. So I might just go through a couple, try to get through as many of the audience questions as we can. So this is a question, let's have a look. And this is a question sort of going outside the health system a little bit, but it says, what can happen to better support people and families and carers interacting with the justice system and prisons and the transition process when someone exits prison? So who would be, probably Wayne, or who would like to address that point about helping people when they leave prison so that they feel supported?
Well, I suppose, Sophie, it's, mental health in terms of what we don't want to see is a revolving door. And what we have to recognise is that mental health injury or illness sometimes drives the criminal justice system, just like drug and substance abuse drives the criminal justice system at times. And often all of these factors can join up in terms of a person's life and lead them to a situation where they become incarcerated. Simply just opening the door, letting somebody out of prison and saying off you go and on your own is simply a recipe for our members turning up the next day and meeting that person either in crisis again or in a similar situation where the system becomes, again, less empathetic and forgiving the longer and the more recurrent they confront it. So the second time they have an intervention or the third time they have an intervention, the degree of support that the system offers is less and less and less. Yeah. And so it's really important that that first opportunity is the right opportunity. In the criminal justice system, we see increasingly the use of specialist courts that deal with, for example, people with drug and alcohol addiction. Well, I'd suggest that in genuine cases where people are challenged by their mental health circumstance, that proper sentencing and proper support in that system that has account for and regard for the situations that people are confronted with in terms of their mental health would also assist people not only get the support that they need. I mean, it's not an easy way out of the system, no. But it is making sure that justice is administered in a way that aids and supports rehabilitation, both in the criminal setting, but also in the setting that actually drives that behaviour in the first instance.
And I think, Sophie, sometimes what gets lost, in this reform environment, we talk a lot about system navigation and the ability of consumers to navigate the system. I think it's going to be vitally important in this time of reform that we think about navigation as something available not just to consumers and carers, but to other service providers as well, because, there are a lot of different organisations providing mental health care and support in prisons. And for those organisations where often they're discharging people with very short notice, system navigation is equally as difficult for those workers and staff in prison settings who are trying to put in place supports for people who are being released from prison at short notice, because they're the ones, they're trying to make links to the very small number of existing services, which are largely the clinical services, and they need to be given the resources to make sure that they can get access to community-based supports as well as clinical teams through health services as well, because I know from my previous experience at Forensic Care, staff would relate sitting on hold on triage lines for people who are about to be discharged in a number of days for hours and hours, and that's
so you want to make it as easy for them as well as the person itself.
And we want to make it as easy for those people who are providing mental health care and support in prison to navigate into the system to the right level of care, because often those staff know the right level of care, it's just that they can't access it when they've got a prisoner in front of them who's going to be released in 2 days. It's it's a vital link that sometimes I think gets missed.
What's sometimes interesting, Sophie, is that sometimes incarceration for the first time delivers a person with a degree of structure in terms of their treatment. And as surprising as that sounds, sometimes the release of a person absent that connection that Tom's talking about sets backwards some progress that they've actually made. And it's the small positive that comes from that person having been incarcerated at times can be that the structure for the first time has found the individual. The system finds the individual, and if the two systems don't join up, any small benefit that might be received is lost. Person goes.
Yes. So ideally, I've done some work with Justice Health in New South Wales, and I've heard that said, and I've heard people talk about that who've been in the system saying that was the first time they actually received the mental health care that they really needed, was unfortunately when they were in jail. And so ensuring that there was that continuity of care when they got out would be really important. So we're going to do what? We're going to go about 10 minutes left. We're going to do one more word cloud, which we might pop up now, which is for the audience. What are the biggest enablers for effective crisis support? And so if we pop that up and everyone can put their viewpoints in, but while we do that, I might just go through to all the panelists and just get you to reflect on, you know, we're in the consultation phase for these community mental health services. You know, what's the key thing that you would like to see in these new services to ensure that as much as possible, people don't end up needing the crisis care that you provide? So we might start with, I think Fran might have just lost her camera. We'll start with Mick. What would you like to see, as much as possible, what would you like to see in these community organisations to ensure that they don't end up needing to call your members out?
Yeah, I guess, Sophie, there'll always be a need for ambulance, like there'll always be a need for police, because we can't prevent every crisis. But it's what's important is availability. And so we hear so often in patients that we see that the services have been unavailable to them. And so, you know, empathetic healthcare that's available to people when they're in lesser need than in crisis is ultimately, I think, the cornerstone of this. But, you know, crisis intervention also needs to be available, and that's people who are mental health professionals being available for those in crisis, not just police and ambulance. And then understanding that the system will, from time to time, need all of us to be there. And in that system, all of us need to be connected. So we all need to be on the same page. We need to be trained the same way, and we need to have common expectations for that patient's outcome.
And Tom, what about from your point of view? What are one of the key things that you really want to see in the community organisations, the new services?
Yeah, thanks, Sophie. Oh, look, I mean, I think just picking up on that it's really important that these are coordinated. We have no line of sight at the moment about how the state community-based local mental health and wellbeing centres will link or relate to the Commonwealth-funded ones, and we're at serious risk of duplicating and creating a more complex system for the people who need to use it. I think it's about coordination at the operational level. So wherever these centres are, there's an open and regular conversation between the people who are the first points of access for the community. And that includes the police, it includes the first responders and the ambulance service, so that everybody knows what's happening in the community in terms of responding to their mental health needs. So I think that coordination is really critical. And when it comes to the service delivery, I do think it's reassuring that you know, of equal size in the word cloud is peer workers. We need to make sure that the responses that we're putting in place in the community are different to what we have now, different and coordinated. So, you know, having a peer lived experience at your first point of call into this part of the system, and as your last point of call, and the follow-up as well, I think is going to be critically important.
Yes, definitely. And Fran, we'll just get you to unmute and give us your viewpoint.
I agree. I think there needs to be a lot of co-design and co-production in how these services look in the future, and they need to, and we need to embed our lived experience workforce as a profession.
Yes,
they are their own discipline, and that means that they need to have all of the supports around them that other disciplines have, and we correct them from the top down.
You're just breaking up a little bit there, Fran, but yes, we heard in the session earlier today. Yeah, we heard in the session earlier today from Eating Disorders Victoria, just how the amazing work they're doing with lived experience people, and how it is just treated as a profession, not just as an add-on. And Wayne, we'll just go to you for we've only got a couple of minutes left, but just your response to what you would be hoping to see in these community mental health services.
Well, I'd like to see the definition of what our frontline response is turned on its head. I'd like it to shift from police to our peer workers in the community. I'd like to see it shift from police to mental health clinicians, to PACER co-response models. The investment needs to go to the people with the skills and the capacity to do the work. That's the only way we'll get ahead of crisis. It's the only way we'll turn crisis into a more empathetic response. And it's what needs to happen if we want to turn that escalating trend of police attending people in crisis in the community into something that's more akin to a downhill slope.
And we've got a couple of more minutes left, but some of the other, we can see in the word cloud that peer workers, lived experience. It's also highlighted early intervention as being really important as well. And maybe Tom, how important is early intervention, and do you think there's enough of a focus on that? There will be enough of a focus on that with these new community models that are being set up?
Look, my fear is there won't be, and I think we have to accept that if the Royal Commission asks us for a paradigm shift, we need to, the Department of Health needs to communicate in a completely different way, that services, be they community-based ones like mine or clinical services like Fran's, need to communicate with each other in a different way, but also with first responders. The goal of the Commonwealth-funded adult mental health centres, the Head to Health, is to provide a level of early intervention, and certainly we see that in the crisis work that we're doing in Adelaide, that there's a degree, because you don't have to be in the most extreme forms of crisis to go into that service, and so that form of early intervention is really important. But we've also got to think about digital pathways and technology-based pathways as well for people to get early intervention. But again, that comes with the writer. It needs to be coordinated. They need to link up, and at the moment we're not doing that in Victoria.
That's a good point too, Tom, because not everybody necessarily wants or needs to get help face-to-face. Some people like the option of having, getting care via an app or via someone they can talk to online, or a chat room or whatever. So I guess, and the ideal is just to provide people options, isn't it? So that then they can choose whatever care they feel is going to serve them the best. At the moment, that's not necessarily happening at the moment. But look, we're almost out of time, but I don't know if we've got Fran there. I think she might have dropped off, but I just wanted to thank everybody for being part of this session. It's been amazing. We could probably talk for another 45 minutes, but we've got a full program. So I just wanted to say a big thank you to all of you for being part of this session. And in the audience, if you can just give them, I know you can't see the audience, but just give our panel a big virtual round of applause. So thank you so much for your time, Wayne and Tom and Mick and Fran. I think she might have dropped off, but it's been really amazing. And yeah, let's hope that that the sort of care that these new centres can provide, we can shift that paradigm that Wayne talked about and get that curve going the other way, which would be really, really ideal. So thank you very much. Thanks everyone for your time. It's been really amazing, and really enjoyed having all of you as part of this session today.
Thanks very much.
See you later. So we're going to move on now to another fireside chat, and I just wanted to, there was a discussion of suicide in that last talk, and we are going to be now talking about suicide prevention. So just a reminder that there are helplines available, and we will be putting them up at the end of this session as well, if you do want someone to talk to and reach out to your helpline for support. But we're now going to move on to a fireside chat to talk about suicide prevention and what it might look like in the new model of care. And we're delighted to have Simon Pont with us, who is the Director of Quality Systems and Practice at Suicide Prevention Australia. So Simon, welcome. Thank you for being with us. It's great to have you with us. And just a reminder to the audience, again, we want you to take part in this discussion just as much as I'm here asking questions, it's about you asking questions as well. So if you have a question for Simon, go to menti.com. You know how to do it now, or everyone's getting good at it. So pop your question in, vote for whichever question you like the best. And I see all the votes and I try to answer all the questions that I can get through in the time. And I'll just ask a few questions to Simon first to kick us off. So Simon, we've been talking about, you know, the new model of the community-based mental health services that are being designed at the moment. And I'm really keen to get a bit of insight from you into what suicide prevention and response might look like in this new model.
Thanks, Sophie, and thank you very much for the opportunity to share with you a little today. I do just want to start by just acknowledging the voice of lived experience and pay my respects to those who are impacted by suicide and those who are bereaved by suicide. I think in terms of some of those insights, I thought I might, by being an answer, just draw on some national insights. There's been such a momentum around suicide prevention at a national and a state level, and there's a few insights that may be relevant to the community models. In particular, we know that suicide arises from a complex interaction between many variables, risk factors and triggers in a person's life. And certainly at a national level, and some of the work that's been done by Christine Morgan and others, the Royal Commission in Victoria, we're missing those opportunities to reach people early in their suicidal distress and prevent the onset of suicidal behaviour. So some of the ways that we can start to think about that is certainly we need to, any models need to be informed by lived experience, and lived experience must shape the development of those outcomes. That needs to be co-designed with those who have a lived experience of suicidal behaviour. But also there's opportunities to respond early to distress. People encounter a range of stressors across the lifespan, and it's at those transition points and times of often disconnection from their support networks that we can start to think about how we can target services. It may not be solely in the domain of what we traditionally would see as suicide prevention, but things like adverse childhood experiences and family disruption, opportunity to be able to respond early in those instances, but also think about how we can target our support to priority populations. So those population groups that can be disproportionately affected, it's important we consider all the factors associated with that and think about how we might be able to target support to that. But equally, our models need to be informed by evidence and have evaluation as part of that. And at Suicide Prevention Australia, we have rolled out a model of accreditation, and certainly would see that any programs and services that are funded need to have an accreditation embedded within that to ensure that those programs are safe, high quality and effective.
How do we, this is something that I'm really interested in, and I did a story on it last week for ABC about how do we reach out and connect with the part of the community that doesn't currently engage with mental health services, but yet are overrepresented in that group of people with suicidal thoughts. How can we ensure, like, for example, that these community models are not just not necessarily just replicating what's already there, but also looking to what you just suggested, that, you know, that not necessarily, you know, they're just the traditional mental health services, but that we're looking outside that as well, for particularly when it comes to suicide prevention, because there is a big cohort of people who are not really engaged with the sector at the moment, isn't there? Definitely.
And I think your earlier conversation in regards to the criminal justice system, I think aligns closely with that. And Suicide Prevention Australia commissioned some research around those interventions to reduce suicidal thoughts and behaviour in people who have contact with the criminal justice system. And I won't go into all the details, and certainly your previous panellists covered a lot of that, but certainly people who come into contact with the criminal justice system are at an increased risk of suicide due to poverty, homelessness, stigma, neglect and abuse. And that I think there's, whilst that's in relation to the criminal justice system, there's also alcohol and other drugs, insecure housing, the child protection system and adverse childhood experiences. So certainly I think there's an opportunity to be able to respond early to distress and be able to work in collaboration with those service providers who are already working in that space, but then also ensure that they have the skills and experience to be able to respond to that distress. So ensuring that there's the support available around workforce planning, gatekeeper training that may be rolled out to staff as part of a workforce plan, but also gatekeeper training and that community-based training that might be able to be rolled out to those community organisations. There's also, I guess, in terms of the priority population groups, so those groups that are disproportionately affected, it's important that we consider all those factors that lead to distress and address those through targeted responses where required. These groups include men, young people experiencing significant levels of distress, Aboriginal and Torres Strait Islander people, the LGBTIQ plus community, those from culturally and linguistically diverse backgrounds. We need to ensure that our approaches also work at a rural and remote communities as well. So when we're thinking about those community models, it's not a one size fits all, but think about how we can be able to tailor those responses to the needs of the community.
Yes, that's a very, very good point. And also older people as well,
definitely,
given that they are, again, overrepresented in suicide statistics. So we've got a few questions coming in. I might go to those, and don't anyone in the audience jump on in and ask a question. So this questioner is asking, we heard earlier about intervening in crisis earlier. Are there evidence-based training programs that friends and family can access to learn how to support someone with thoughts of suicide? I guess they're asking, you know, based on your focus on evidence-based and quality. What would your advice be?
Certainly, there's a range of training programs and providers. Some that are run online, others that are face to face, and certainly some of the larger programs that have been run around training. Mental health first aid here in Australia rolls out a range of programs. Equally, Living Works Australia rolls out a range of programs from the online training that can be provided, so people can access that. Equally, there's the face-to-face, whether that be a half day or a full day type of training. So there's a range of different training that is available, and part of it would be identifying the training that would be suitable for the individual or the community. So, but equally, as I mentioned before, in all of suicide prevention, it's important that any of the training programs and services are of a high quality. And so some of those training providers are going through an accreditation program. And so if you are looking for those programs that meet that standard, then, or working towards that standard, then there's a list of those on our website at Suicide Prevention Australia, and you can access some of those services.
Oh, that's great. Thank you for that. And that's really good advice to go. If in the audience, if you're interested, definitely go to Suicide Prevention Australia's website and you can find those list of providers. Here's another good question, Simon. What's your advice for enhancing the clinical and non-clinical workforce capacity and capability, particularly in suicide prevention?
Yeah, great question. And I think it's not an either or, it's both. So in suicide prevention, we need a diverse workforce that includes the lived experience-led elements, the peer workforce. Quite pleasing throughout Australia, there's been quite a shift in focus towards peer-led initiatives. Many of the people joining us today would be familiar with the Safe Spaces model. In Melbourne, you have the Safe Cafe, but these are peer-led, community-based suicide prevention initiatives that are person-centered and aim to really respond to the individual needs of the person who seeks help. But then there's also the clinical element as well, and ensuring that the clinical staff who at times may be the first point of contact for someone who is in distress. We know that first time that someone reaches out for support is a critical moment and is significant in their overall trajectory of recovery. And so ensure that those clinical professionals are supported, but equally that there's a workforce strategy around that so that they have the skills to be able to respond to the individual who might be in distress. And certainly it has to be all of the workforce and being able to flex accordingly to the needs of the individual.
Okay, thank you, Simon. Now I've got a couple more questions, so we'll get through as many as we can. This audience member is asking, young women have the highest rate of increase in suicidal behaviours over the last decade. How can we better support girls and young women at risk of suicide? And I'll get you to answer to that, and then I'll also get you to answer the other end of the spectrum, the older Australians as well. So given that they are overrepresented in suicide statistics. So let's start with the younger age group, the younger cohort. What needs to be done? How can we better support the young women? And then also, how can we reach out and make sure we're supporting the older people as well, who might feel like they're left out of, or a bit overlooked with existing services?
Definitely, and I think for both, it's about ensuring that we are tailoring our services and programs to the needs of those population groups, whether that be young women or older persons, and ensuring that we understand the reasons for distress and being able to respond early to those reasons for distress, and certainly for younger women, there's a number of programs that are doing a lot of great work around that. Origin is one who are working around with young people, and their model is also informed by having a young person's peer-led advisory group as well. So, but in terms of the older persons as well, there's a number of touch points again. So ensuring that whether that be through the GP or the other services that might be provided to the older person, that they have the skills and experience to be able to respond to distress, to be able to intervene early to those distress. That's right.
Recognize it, because if you think about those two examples, the sort of services and support that those two groups would need are almost completely different. You might imagine that that young women might be, obviously everyone's situation is different, but you might imagine that young women might want to be more likely to engage maybe in a digital service. They might want to talk to someone online first, maybe, but then you're not going to necessarily get an older person wanting to go on Instagram and go into a chat room. So it's, in a lot of ways, I guess that's part of the challenge, isn't it, to ensure that you are creating services and support that meet the needs of the people where they are at that time.
Definitely, and I think I think you're right that there's both through the face-to-face services for young people generally, but in particular for young women, the peer-led initiatives, and there's a lot of great work being done around that sort of those sorts of supports. Then there's the e-mental health and the online type services, where people may engage and young people may want to engage at that level, rather than reaching out to someone who is face to face. And you're right, and the older person, that's going to be very different. We need to ensure that we're able to tailor those responses to the needs of that population group. And I think, as I said before, it can't be when we're talking about suicide prevention across the lifespan, it can't be a one size fits all.
Now, I've got to talk about, we just mentioned technology, but we've got a question here about how does Suicide Prevention Australia view or support technology in proactive approaches to suicide prevention?
Definitely. I think there's a range of opportunities around technology. Certainly for any technology that is being rolled out, whether that be the online chat rooms, the apps, or any of the other range of initiatives, they need to be safe and of a high quality. So when we're thinking about online, think about the safety. So if someone is in distress or has expressing thoughts of suicidal thoughts, is there the appropriate safety around that to ensure that that person can be supported and linked into other supports, but equally that the conversation, we know that some of the conversation around suicide can impact people who are having their own lived experience of suicide, to ensure that there's that safety element for anyone else joining in that conversation. But there was a lot of great work being done in Australia around those e-mental health online initiatives, and part of the work that Suicide Prevention Australia does, we manage a national research fund, whereby we're partnering with lived experience and program providers and researchers to be able to fund some of these initiatives. And there's a lot of great work that's being tested, has a strong evidence base, and being rolled out in diverse populations and communities around that e-mental health online type space.
Oh, that's great. Another good question here is, how do workplaces know where to start when educating employees about suicide and suicide prevention? What would be some advice or tips that you would have? So this might be an employer who's asked that, someone who might be, running a business and wanting to make sure that their employees are educated about suicide and suicide prevention.
Definitely, and there's such an opportunity around the prevention of suicide if we can think about training up diverse workforces, and that includes both workforces that would be in the suicide prevention sector as what we traditionally might see it, but also those workforces that you're referring to, Sophie, that might be a small business or the HR manager in an organisation. We need to build that workforce capacity and think about how we can ensure that those workforces have the skills, the knowledge, the experience to be able to respond to someone who might be in distress, as we've spoken about, to be able to intervene early at those life transitions, but equally be able to respond to someone who may be part of their workforce of their organisation who has a lived experience of suicide, or the carer of someone who is experiencing suicidal behaviour. And at Source Limits Australia, we acknowledged that this was something that was quite significant in being able to develop that workforce capacity, and developed with our membership a suicide prevention workforce framework, competency framework, which really was about enhancing the capacity of the workforce, the same way that many workforces roll out CPR or first aid training. The opportunity to roll out a framework that ensures that all staff, regardless of their role within the organisation, have the skills, the knowledge, the experience to be able to respond to distress. And it's informed by and brings together a range of knowledge experts around workforce suicide prevention and training, but it's really provides an opportunity to be able to tailor the needs of the organisation to their specific workforces.
Yeah, and I just on that matter, I just the story that I did last week for ABC on targeting those groups of people that might not necessarily engage with mental health services at the moment, but who are having suicidal thoughts. We ended up profiling and focusing on I don't know if the audience has heard of a group called Mates in Construction, and it's an organisation that works on construction sites, which are again overrepresented in suicide statistics. And the case study that I interviewed and the man that had helped him was like it was really amazing talking to this young 33-year-old construction worker, father of 5, who had been having some difficulties, but was on a work site where this organisation, Mates in Construction, had a number of people who worked there and were trained to recognise the signs that this guy was having problems. And straight away he was able to get the help that he needed. He was told by John, the guy who worked on the site, you know, I'm here to help you, whatever you need, I'll be there to support you. And the difference that made in that one person, for that one guy, meaning he got that help that he needed, the support. He didn't have, because he was a really good example of someone who hadn't engaged with a doctor or a GP, didn't want to burden what he said was burdening his partner with it, because the partner had 5 kids to look after. But thankfully in the workplace they had that charity there to make sure that he got the support that he needed, and now he's doing so much better. So it just shows the value of having a service like that, or sort of no matter where someone is, there's an opportunity for them to get help wherever they are, whenever they need it, whether it is at a workplace, you know, face to face, online, you know, wherever. I guess the more opportunities there are in different touch points, the better, is that what you would suggest, Simon? As long
Certainly.
as it's quality care.
Certainly, and I think the example, Sophie, is a really good one around that. Around those touch points that we know across the lifespan, there may be a number of instances where people can respond to the person who might be in distress, and being able to roll out a program like Mates and so tailored training to that workforce and that population and group allows the staff to be able to, or the workers to be able to respond to that distress, to have the skills and confidence to be able to respond when someone says they're not doing okay.
Yeah.
And being out and then knowing what they can do, because I think for most people, they don't want to do any harm, but being able to provide some skills around how they might be able to respond, and being able to ensure that the person is then linked into those supports that they need is crucial.
Yeah, and you could obviously tell from this example that it had made such a difference to this guy's experience, and literally he'd only gone back to work a few days I did the interview with him at the end of last week, and he'd only been back at work for a week or so. So it was all quite, you know, had happened relatively recently. So, but he was able to be back at work and talk about it and have his photo taken and end up on an ABC website. And so I just think that was a great example of sort of meeting people where they are in terms of getting the help that they needed. So, and that's obviously, you know, something that is just so important to ensure, particularly those harder to reach groups that are really missing out at the moment.
Yes.
And yes, someone is saying, yeah, lots of older people are tech savvy. Yes, I definitely agree with that. We FaceTime, my father-in-law is 91, and so we FaceTime him. We FaceTime him every night, and he is in a retirement village. But he live streams all the church services from his area into the retirement village. So yeah, I'm definitely up on older people being tech savvy. So I didn't mean to suggest that older people weren't tech savvy, just that it's good to offer people a range of options, I guess, so that wherever they are, they can find the help that they really need. So we're nearly running out of time, Simon. Was there any last points that you wanted to make just before we go, just particularly in terms of the community models and what you really want to see to ensure that that, you know, suicide prevention and response is a factor in this new community care that's going to be rolled out soon?
I think just to echo what we've spoken about over the last little while, but that the suicide prevention response needs to be tailored to the needs of the community, and that may look very different in a variety of different communities, whether that be metro or rural, regional, but equally the community themselves may have some specific needs, and we need to ensure that those programs and services around that response are tailored to those needs. But equally ensuring that any of those programs and services that we're thinking about in terms of the community model are joined up. So we're not thinking about mental health or suicide prevention in isolation to a range of other social determinants. And whatever those programs and services are, need to be safe, high quality and effective. So provide the community with that assurance that those programs are to a high standard.
Definitely. Oh, look, thank you for that great wrap up at the end there. And thank you for all your insights. It's been amazing having you as part of the program today. And we really appreciate your time. It's been really, really good to have you on board. And we had lots of questions. We didn't quite get to all of them, but thanks to you in the audience as well. And thanks, Simon. So we're going to take a short break now, and we're going to be back. And just because the discussion was about suicide, and we're just popping up the helplines like we do in every break. So if any of this discussion you're feeling that you do need some extra support, please reach out to one of these helplines that are up on the screen now. We're going to take a short break, but we'll be back at 3 o'clock, and we're going to have a panel discussion where we're going to reflect on all the amazing things we've been talking about from today and from last week as well. So we'll be back at 3 o'clock. Welcome back, everybody. And I'm looking forward to the last session of our symposium today, where we're going to have a little bit of a look back on what we've talked about today and last Tuesday. So we're going to reflect on the key points, and we've got a great panel set up for this particular session, and how we're going to be looking at how this new community model of care can ensure that everything lines up with the ultimate goal of supporting recovery of consumers and people in the mental health space. So I'm delighted to introduce our panel of great experts. So we've got Nicole Bartholomews, who's the Chief Executive of Co-Health, Nikki Wynn, the Director of the Services Wellways, and you might have seen the ads for Wellways during the break, Neil Turton-Lane, the NDIS Manager of VIMIAC, Marie Pugh, the CEO of Tandem. So I'll just wait till everyone is on. Nikki, I can see Nicole, Neil, and Marie. You just need to get Marie to turn her camera on. And as always, the audience, we definitely want to hear your questions. So actually, before we hear the questions, we're going to we love word clouds. We're really into word clouds, if you haven't noticed. We're going to do a word cloud where we're going to ask, we want you to reflect on in the audience, what are the key takeaways from today and from last Tuesday, if you were here last Tuesday as well. From each of you in the audience, we really want to hear what are the key takeaways, 1 or 2 words that you would like to put up to just give a bit of feedback on what you've taken away from this session and last Tuesday as well. So welcome everyone on the panel, Nikki and Nicole and Neil and Mari. So thank you very much, Marie. And here we go. Here's the slide for the word cloud. So yeah, we would love to hear from you in the audience. What are the key takeaways from this symposium and last week as well, if you were around? But while we do that, I'll just get my little Menti up on my phone as well. So here it is. It's great. I love this. I mean, this is an example of where technology is great, because it means we can hear from the audience. Here we go. Need time to be authentic. Collaboration, great ideas, lived experience. That's great. So let's just reflect on some of these themes, but also maybe go to the panel as well in terms of what they've taken away as some of the key things that we need to learn as we move forward in this consultation period for the community models of care. Maybe we'll start with Nikki, to start with you. What are some of the key things that you've taken away from today and also from last week as well?
Thanks, Sophie. Yeah, absolutely. I see that lived experience has come up quite large there, and it certainly has been a theme both last week and today. And I was particularly impacted by Craig Wallace's talk today. You know, he really from VMIAC, the new CEO of VMIAC, and he actually talked about asking what consumers most want, and it is that lived experience, that peer work. So I found that really interesting, that the people want more than that medical model. And Craig shared his story with us about how important it is to him to feel useful after years of accessing a mental health system that had made him feel like a burden, and that it appears that lived experience and the peer workforce are really crucial to making that happen.
And isn't that a wonderful just change in mindset for someone to no longer feel like a burden, but to feel that they would be of use and of value to helping a system rather than the burden. And if more people could feel like that, I think that would mean that we're heading in the right direction in improving the mental health system, definitely. And what about Nicole? I'll just go to you for some feedback while we're waiting for more of the audience to give us their key takeaways. What are some of the things that you've taken from today and from last week, if you were with us last week as well?
Thanks, Sophie. Look, I think collaboration, which is large there in the word cloud, is really important, and it has come through both last week and through today's sessions. I think that just recalling from the panel presentation last Tuesday, the partnership panel, where really talked about the importance of good collaboration, the importance of building those partnerships. So commencing with, you know, trust and respect, building those really good relationships, so that as a sector, and there's many providers in the sector, we can really collaborate well to deliver a joined up system. And of course, central to that system are people with lived experience. So I think, you know, that collaboration is a really important theme from the 2 days.
Yes, I agree. And certainly last week it was fantastic to hear the collaborative nature and the holistic nature of some of the services that already exist, and the hope that the new community models will offer that holistic and collaborative approach to helping people, so that you not only, because people don't exist in a vacuum, you know, as an individual, you have a number of needs that need to be met, and having services and people collaborating together means that you're more likely to have those variety of different needs met, rather than having to sort of try to negotiate a very disjointed system completely. Absolutely. And so that's a great point, Nicole. Thank you. And Neil, what are your thoughts? What are some of the key things that have come out of these 2 days for you?
Oh, thank you, Sophie. Look, can I just thank Mental Health Victoria for all their work in putting together the 2 days of this symposium. It's just been great, and it's given, there have been so many takeaways. I could open up my own franchise. But no, seriously, I think, you know, my big takeaway was around, and you know, developing an approach that kind of creates social and emotional well-being at a community level, and the idea of communities being in control and having a new narrative moving forward about how we support people in distress and how we've all got a part to do that.
Definitely, definitely. And Marie?
Thank you, Sophie. I'd like to begin by acknowledging the traditional owners on which we meet, and particularly pay respects to the traditional owners of the Wurundjeri people of the Kulin Nation, and pay my respects to elders past, present and emerging. But I also want to acknowledge those living with mental health challenges, their family, friends and supporters, generously sharing their lived experience to I guess, inform this reform process, as well as the allies committed to authentic reform here today. One of the things that's really come through for me is a commitment, at least in theory, I think, to the importance of co-design. And I think that one of the things, though, that's also come through to me over these 2 days is the importance of the time and the tailored nature of that work. So when I heard a lot of the speakers like Sheree from VACCHO and other key speakers, and Craig himself this morning, Craig said something that was really important. He reminded us that just because we're working on something together doesn't mean we're doing it well. And Sheree really pointed out the fact that in order to achieve cultural safety, we need to take time, we need to think about that, we need to really listen deeply and think about how we can be humble so that we can learn from others. And I think that the Aboriginal social and emotional wellbeing framework is something that is really key, and that I think the mainstream system could learn a lot from. I think the other thing that the others have mentioned is lived experience. I guess that in the way I interpret it, many people have actually explained that as being consumers and their family, friends and supporters, but that's not always the understanding. I'm hopeful that that will be the understanding. I know Minister Molino wants it to be. But there's always a fear, I think, underlying all of this, that with the speed of the reform and with a willingness to put runs on the board, that things slip off. And the history has shown us that, unfortunately, that family engagement and family peers or carer peers tend to be the thing that drops off the end. So I guess that's something that I keep in mind.
You want to make sure that we're not, even though it's good to see progress and obviously you want to see things move forward, you don't want it to be at the cost of important elements being left by the wayside, like carers.
Yes, absolutely.
So I might just go to, we can open it up to the audience for questions as well now. So if you want to ask a question, you can do that. Just go back to the Menti, and if you've got a question on the panel about orienting towards recovery, please feel free to do so. And so we'll as well as reflecting on what we've heard over the last 2 days, we'll just talk about, which is sort of what we've been covering as a whole, you know, the key barriers and the key enablers. We wanted to look at both ends of the spectrum. You know, what are the things that we need to look at to overcome, but also what are the things that are more likely to be successful and to enable successful community service mental health models. So we might just talk about the enablers, and maybe Nikki, from your point of view, what have you heard that sort of fills you with optimism in terms of that these models will be what we need, particularly these community models will be what we need to help consumers get the help that they need?
Thanks, Sophie. I think the way that we're talking about collaboration is exciting. I think last week Damien Ferry sort of mentioned that vested interests can bring about competition, but we've all talked about how we can make partnerships work and how important it is for all of the players to be in an equitable partnership, one in which power is diffused and expertise is valued across all of the different fields. And I suppose one of the things that I thought was, a really exciting point from Jill Callister last week from Mind. Jill said that the partnership needs to start prior to that design for a full partnership. And that really resonated for me. And I think that if we're, as we are consulting now for the local mental health and wellbeing centres, if that, and there is an element of that, of course, that will need to be standardised, but an element of that can be bespoke to the local community. And if we are designing that from the outset together, that excites me.
And it was also really good to hear Katherine Whetton in her update today again saying to the sector, we want to hear from you. We want you to be part of our journey. And I think that's a really important message to not just to hear, but to see it in action as well. It's not just, she's not just saying it, but you can tell by the way they've set up the consultation that actually they want people. They want the input of the sector and lived experience, which is so important. And Nicole, from your point of view, what have you taken from the last 2 days about the key enablers, the things that will help, hopefully help these models be a success and deliver the sort of services that the sector's really wanting to help consumers?
Sophie, it's very similar to what Nikki said. I think, the fact that we're having these conversations is so exciting, that we're open to listening to what the issues and challenges are, that we're thinking about what we've learnt from the past and we're wanting to take that forward in a collaborative way. I really think, the opportunity to have everyone at the table is so important. We all bring strengths in the work that we do, and that will really add value to the design of a new system to support community. And of course, having the community there present in those conversations is so critical. So I think, just that opportunity really, and it was really great to hear Katherine say that this morning, but I think, having everyone at the table, building those partnerships right from, day one before those models start, and recognising that everyone has a role to play, and there's lots of strengths that we can draw on here.
And Neil, what about from your point of view, what do you see as, given the discussions you've heard as well over the last 2 days, the key enablers that will ideally get these community models of care developed in the way that have the best chance of succeeding for consumers and for their families and for carers?
Oh, look, I took a lot out of those discussions around inclusion and diversity. I thought they were fantastic discussions. And I think if we can keep that in mind moving forward, that, we have more diverse voices and communities at these tables, that we also kind of like listen to and respect to kind of like specialist organisations that hold knowledge and that can bring insights that more mainstream services or might not have, or systems might have. I think, and finding ways to, to properly resource people to be engaged in this process, I think is super important. And I think Marie talked about, and I heard throughout the conference people talking about giving it time, not rushing it, and I agree. Like we have to make this time meaningful, and the best way to do that is, I think, in the way that we're heading now, so I think they're all great things. I think if I have one thing that I think I would like to see, perhaps with a bit more focus, it would be our current Mental Health Act and its impact on what we do, because really, it's sitting there, and it in some ways, you know, it kind of like restrains like some of the support that we may want to provide to people, or some, you know, like new changes in the way that we work. So we're going to keep that in mind, you know, that idea of, you know, and I think in that discussion around suicide prevention, you know, there was a lot of discussion about looking at risk in new ways, and new ways of engaging and understanding risk and having conversations about risk. I think all those things are really important if we want to see change happen.
Thanks, Neil. And Marie?
I think one of the interesting things, picking up on what some of the others have said, particularly Nikki mentioned this, is that really to achieve our shared goal, and I think it is a shared goal, we need to build the reform table together, and then we need to have a broad range of people and service types around that table, where consumers, their family, friends and supporters can see that those people reflect the diversity in the community, and that they're all natural partners, and that then the power is shared with service providers. And I think that's something that really struck me, that's come through the last couple of days. And the other thing today that really struck me when we were talking about emergency services and emergency responses was the need for compassion. We've talked a lot about the need for compassion, but I think compassionate leadership and allowing staff to understand what that means in their work, and supporting staff to be compassionate in their work, which means them having the time to do their role in the way that they intended, is so important. And I thought that was really reassuring.
Yes, that's a good point. It's hard to be compassionate if you're so overworked and so overwhelmed that you don't actually have the time or the emotional bandwidth to give the level of care that you need to give to somebody. So I think that's a very good point. It's also, compassion comes from the way the system's designed to allow you to be compassionate and not be so overwhelmed with what you're doing. So we've got quite a lot of audience questions coming in, so we might go to that. And this is on compassion, so let's just ask this one. It says, how do we teach leaders to be compassionate when people are more focused on professional or business objectives? Can you teach compassion, Nikki?
I think, you know, you need to recruit for compassion, but there was a lot of talk about how I suppose you create a sort of a culture, and we've talked a little bit about that over the last couple of weeks. And I know that Jackson, Fairchild, they mentioned that having diversity in the team isn't enough, but people need to feel safe and included. And that's a cultural, but it's also articulated in our policies and in our research. And Adele also, just before when she was talking about intersectionality, you know, talked about a whole of organisation approach with, you know, the governance, the management, the delivery and the experience of service. All of these are contributing factors to the culture that we want to build. And if our values say compassion, but everything that backs it up behind it, from our recruitment through to our policies and procedures and our processes backs it up, then we can truly live and breathe our values.
So it's not just paying lip service to it. And that's a good point. So this is an interesting question. Some workers seem to get the idea of recovery-oriented care without explaining it, but others don't seem to get it no matter how much you explain it. Can it be trained? Can you train people to understand the concept of recovery-oriented care, or is it about getting the right workers in? So this is, I guess this is a sort of workforce issue. So who would like to, Nicole, did you want to address this one, or yeah.
Yeah, look, I think it is absolutely an orientation, but I think it is something that, I don't know if trained is the right word, but I think it does also come back to values and culture. And really, like from the outset, you're recruiting individuals or a workforce that are aligned with your values and culture. And the orientation is towards recovery, working towards recovery, partnering for recovery, then that's the framework that a workforce would work within, and they're supported and coached to do that. But absolutely think that it's something that can be learned. It doesn't, it absolutely can be learned, but it actually needs to occur in the right culture, in the right space. And just picking up on what Nikki was saying, like, I really think that that culture of compassion starts within the organisation. So a service user's experience is always going to be impacted by the experience of staff working in an organisation. So if we can set the right culture, if we've recruited people who are values aligned and we're treating each other and working with each other in a compassionate way, then that's the role modelling that occurs for that worker-consumer interaction. So I think it absolutely, you know, what happens at home is the experience that people who use the service experience.
Thanks, Nicole. Now we've got a question about, where is it? It's gone, lived experience. Here it is. I might ask Neil about this one. How do we ensure that we put individuals with a lived experience, oh no, where is it? It was about leadership. It was about ensuring that people with lived experience are not only just have a seat at the table, but also at a leadership level as well. How do we ensure that?
Well, I think the presentation by Dr. Louise Byrne last week, where she talked about the lived experience framework that they've created in Queensland, I think you know, there are a lot of answers in that that you can look at, and examples where you kind of create roles of leadership throughout an organisation. You know, you don't have a glass ceiling around lived experience. In fact, you do the opposite. And I think if you can go down that road, and you certainly gonna help foster lived experience. And and I think, to quote Sandy Watson, amazing kind of thinker about the lived experience movement. Like, we employ people with a lived experience, so we need to support them when they walk through the door. They're not just suddenly workers when they enter that door. They have a whole set of needs that need to be understood. Needs and, dare I say, abilities, talents, capacities, and it's around kind of fostering that, having a real plan around fostering, the potential of people. I think that's definitely the way to go. And and when we're talking about workforce, there are a lot of people with a lived experience who could enter the workforce if it were, the jobs were there, the clear pathways were there, and the safety was there. So if we get all those things right, I think we're well and truly on the way.
Thanks, Neil. And now this is another good question, and it's one that does come up quite a bit. So I think it's important to address it. And Marie, I might get you to answer this one. They're asking, and it's not so much about carers, but about the system as a whole. But they're saying, how will we make sure that the people aged over 65 will be included in the new setups? And then they're saying, will they still be consigned to the ghetto? Well, I hope they don't feel that way. That's very sad that they feel that way, the audience member. But we did want to cover this as an issue, that how do we make sure that that there are age appropriate services that are given, that obviously they're going to be the two systems, but how do we make sure that that older people, that older Australians are not sort of just tacked on to the end of a system, but that there are services that are really age appropriate for older people that are part of this new model?
I think it's a very interesting question, Sophie. One of the things that I think some of the points we've already talked about speak to this, in that if the system is compassionate and responsive, but also if recovery is defined in a relational context, because those of us that support elderly parents with serious mental health issues know that our parents would not be able to continue staying well without that support, even if they're living in supported accommodation, as you know, my mother's living in aged care, for instance. So one of the things we need to understand is when we're talking about the people who have come before us and who have that wisdom and age, we need to think about them in the context of those supports that they have, and we need to provide them with those appropriate responses. And I think one of the things that I noted, and actually my mother's told me this many times, the thing that she values the most is not an appointment with a psychiatrist, but the kindness of all the staff. So if it's the cleaner that's kind, or if it's the person at the front desk who asks her how she is, or the hairdresser that comes into the facility, these are the things that make all the difference, which is why I think if we take a whole of person, whole of life approach, and we think about recovery as relational, we're going to actually get it right from children right through to our senior Victorians, I think.
Yeah, that's a really good point. It's all those little moments, isn't it? Those little touch points and those little opportunities for connection, and the more of those that are made, the better someone's experience and day and life really is, isn't it? So we've sort of covered this a little bit, but I think it's important because this is the top voted question. So it's how do we convey that recovery can be a slow, deliberative and complicated process when we're living in an outcome-driven and time-focused world? And I might go back to Nikki to ask this one. How do we factor that into that recovery is not necessarily, and healing is not necessarily a journey that's a straight line, but it can be like this?
Yeah, I think you know, anyone who works in mental health understands the fluctuation that occurs for people as they kind of journey through to recovery. I think, you know, co-design is at the crux of this, and if we're truly doing co-design from design, then we're having the voices of people who've experienced the system, and we've talked in the last couple of weeks a lot about the trauma of the system, of people's experience going through the system, and so, you know, I think that if we listen to those voices when we are designing the new system, then we will absolutely take that into account. It will be heard.
And I might just move on to another question. And this is something that we've talked about a little bit in this session and over the last 2 days, but you know, it's great to see progress, and it's certainly, you know, these changes have been a long time coming, but the question is, given that there's the often repeated phrase of tight timeframes in relation to reform, how do we ensure that there are quality services and not just quantity? Nicole, how do we ensure that we're not losing quality at the expense of just wanting to get it done? Because yeah, we do know the timeframes are pretty tight.
And I think there's all of us that work in mental health just feel this absolute imperative to be able to implement the changes that we all know that are required and so badly needed. And we do want to be able to get the system out there and the services out there so people can access the care that they absolutely need. And I think it's the balance between being able to make those services available as quickly as possible, but with also ensuring that they're of quality, that they're safe, and that we're meeting people's needs. And I think, you know, making sure that we get that balance right, that we're taking that continual improvement approach. So we're learning and designing as we implement, and we're acknowledging that we're not going to get everything right from the beginning, but as long as we've got a process for reviewing, for learning, and for continuously improving, and hearing the feedback from service users, that's going to be so important to ensuring that we're building a quality system, but we're also, you know, delivering services at the same time.
Yeah, that's a really good point. And making sure that, you know, once when those first 6 services are set up, that there's a good process of evaluation and how's it going and what could we do better, and
what would we do differently next time? How do we build? How do we continually build on that? And I think having, you know, some structures in place so that as we're developing and implementing, there is a feedback loop. coming back, that we can hear from people who are using the services about what's working well, what's not working well, what do we need to change, and building that in to the process.
So we've got a question about, so we'll just go to Neil next, and the audience members asking, what do you think is needed to support recovery, given this is talking about orienting towards recovery? What's needed to support recovery in terms of mental health? What's a big question from the pandemic? But what do you think at the moment, like we are living in a very unique circumstance. So when we think about recovery, what do we need to support people to recover from the pandemic and what everyone's going through, this sort of the collective experience and that everyone's going through at the moment?
I think it's around kind of creating opportunities for people to feel like they've been listened to and understood. And
I'll just get you to speak up a little bit, Neil. I don't know if it's just me, but you just sound a little bit low.
Okay. I think it's around providing spaces and opportunities for people to feel listened to and understood, and supported in kind of finding their own pathway, their own recovery pathway. Everyone has their own answers within themselves, and it's really like just working from that very kind of like walking alongside of a person and supporting them, giving them the confidence and hope that they're there and that there's support there if they need it, but that really, the future is theirs, and, opportunities are there for them to take. And if they have challenges, that there are people there who they can speak to and who will listen to them and perhaps not try to fix them or provide them with answers, but support them around their own choices and their own and validate their feelings. And I think if we can do that, if we can listen to and understand people and support them and make them feel heard, I think we're going a long way to supporting people in recovery.
Thanks very much, Neil. And this is a question about lived experience, and we might just keep going around the panel. Marie, how do we ensure, because we have heard a lot about lived experience today and last week as well, how do we ensure, if we're putting individual people with lived experience into a system, that we're not, if it's a system that's under-resourced and stressed, how can we put them in the system and make sure it's safe for them to be in that system, and we're not going to be doing anything to exacerbate their own mental health?
It's a very interesting question, and I can see where the person is coming from. I think you could think that feels a little bit, I don't know, as though one's making assumptions about someone's inability to cope. And I think that what we've got to think about here is that the mental health system as it currently stands is actually doing damage to a lot of the workforce for many reasons. And I think a lot of that's about the fact that people are working in crisis and they're working in risk management rather than in healing. And I don't believe any professional ever studied or entered the field in order to do risk management as their primary goal. So I think that it's interesting, but I think the strength that those with lived experience as consumers or family members bring is the experience of what it's actually like. And I think that I agree with what Neil was saying before, that what we really need are to see them as allies and as people who can actually give us insights that if we're a worker without lived experience, we're just not going to see it. And I think Tom Bridson on day one, he said something really pertinent at the end of the day that I almost wanted to give him a kiss virtually, which was that he said that, staff are perhaps with someone with a lived experience for one day a month, whereas the family are with them for the other 30. And it's one of those situations that we don't often think about, but I think the reality is that we've got to take a strength-based model and realise that consumers and their families can be allies. We've got to move away from a deficit model, which is where I think we've come from a little in the past. And I really believe that most people in the system, and I'm sure most people that are here today, would absolutely believe in that. And I'm hopeful about that. So I think that we've got to remember that everybody's vulnerable if the system is failing staff as a whole. I think we have a responsibility across the board and not just thinking about it from lived experience staff perspective. Though safety is important for all.
Yes.
In the
agreed.
system.
So we've got less than 10 minutes left. So I thought I'd just go around each of the panel members and just get you to reflect on really your key takeaway that you would like to leave with the audience in terms of what has resonated the most with you about today and last Tuesday as well, in terms of partnering for change and in this journey towards a new community model for mental health. So Nikki, I'll start with you again. What's the thing that has resonated most strongly with you that you'd like to leave with the audience today?
Yeah, I remember last week when Patrick Lawrence from First Step, the CEO, he talked about creating this place of welcome. And he said the lines, unconditional positive regard, that, you know, I haven't heard them sort of said for a while. And it really, it took me back. I was recently doing some focus groups with the LGBTIQA plus carer community, and they talked, a couple of people mentioned how important and how good it felt, not just to be accepted, but to be liked. And I think we know how crucial the therapeutic relationship is to effective treatment and support. And so I hope that our future, you know, in Victoria is creating a collaborative culture of welcome in our centres where people feel like they belong and they feel safe, and so do our staff.
That sounds great. That sounds very good. Nicole, what about you? From what you've heard, what are the things that really stuck with you that you would like to share with the audience?
I think it was, you know, there were so many great speakers over the past 2 days and lots of really valuable insights. But, you know, the one that really struck me, and we all know this, but it was Pat McGorry saying that the centre of gravity has shifted to the community, and it absolutely has. And that's, you know, definitely where it should be. But I think building on that, the opportunity now that we all have to deliver these integrated service models and to actually bring together mental health and physical health and well-being, and to be able to partner with community, people with lived experience across a range of ways to actually deliver integrated care. And to think about that more broadly, so that we're focusing also on the social determinants, which are often the drivers for poor mental health and physical health. So housing, legal services, employment, education, poverty. And I think, you know, shifting that focus, making the community the centre, and really delivering that holistic integrated package of services will really, you know, deliver great outcomes for community.
Yeah, I agree. And we definitely heard in the session today about safety and inclusivity, about, you know, I think Mischa was talking about, you know, domestic violence and family violence being such an issue for women's mental health, and ensuring that those elements are factored into people's care. So it's not just sort of tacked on as a bit of an afterthought, but like the same with, you know, drug and alcohol services. And I think one of you was mentioning the First Steps, Patrick from First Steps, and being able to, Nikki was saying, being able to get that sort of care where you're not necessarily having to go and seek out all these different services.
That's right.
But it's all there for you to treat you as a whole person and meet all the needs that you might have, rather than just you go to one place for one thing and then you have to navigate the system. And you know, the reality is, in a physical health sense, if you were going to be treated for an illness and you needed a number of different treatments, you wouldn't have to go, you'd have someone coordinating that care for you. You wouldn't have to independently sort of seek out all the different parts of the treatment model that you needed. And Neil, what about you? What really resonated with you over today and last Tuesday as well?
I think what really resonated was the process of design and creating new services and new responses, and the idea that, you know, like if, you know, that the consultation processes need to reflect the communities that they're engaging with, and just going back to that idea of starting with community and listening to people, understanding what their needs are, and providing them platforms to maybe start delivering some of these services, some of these responses themselves, and that we can maybe step away from a service-driven model of emotional mental health and well-being to a new form of kind of community, a new form of community. There you go. And so I think that to me was very inspiring, and I think those messages came through over the last couple of days about the potential. I think there's so much expertise and knowledge in Victoria amongst the human services, community organisations, and what the reform process has done is it's opened doors, I think, where before it perhaps was a more of a siloed approach. So that idea that we really do need to collaborate, I think it's something we've always wanted to do, but we've never found the time because we've always been trying to play catch up. But I think what we really need to see is some new models. And because I think seeing is believing, once we start getting things out there, I'm hoping it will catch on, and then the doubters, the doubting Thomases might come on board, the people dragging their feet might come on board to new ways of working.
Exactly. And like, and like we were saying, even if there are some teething problems or tweaks to the model and, evaluation of how the first 6 centres go, the service delivery, that can be evaluated and tweaked and improved even more for the next lot of services. And last but not least, Marie.
For me, there's so many things that's been quite inspiring over the last couple of days. I think authenticity is something that really struck me that has been mentioned many times. And by that, I guess that people don't want to see more tick boxing, and we want services to be tailored. And I don't think anybody wants a one size fits all approach going forward. What we want is that when someone or their family member walks through the door and seeks help, that they're going to be greeted in a warm and compassionate way, and a plan is going to be built around their life needs, and that they're going to walk away feeling as though they were validated and they were cared for. And I think that at the moment we don't have those resources wrapping around people. So that would be an amazing thing. And to move from a deficit to a strengths model, where we celebrate lived experience at the core, but in partnership with service providers, I think is wonderful. And I think everybody around Australia is looking to Victoria to see how we do this. And I think we can. And we can be a world first, I think, because I don't think anybody's done it before.
Oh, that's a great sentiment to end this session and this day on, actually. So thank you, Marie. That was a great summation from all of you, really. Thanks, Nikki and Nicole and Neil and Marie, for giving us a really good wrap up of not only today but last Tuesday as well. And I'll just let's give them all a big virtual round of applause. Thank you very much. Thanks everyone for being part of that session. And I'm just going to say a couple of very brief words in closing, because the panel have really summed up a lot of what I was going to say, which was great. One thing I will say before I just say a couple of things is before we leave this session, there will be an evaluation form. So if you can all not jump off as soon as I finish talking, just do the evaluation. We would love that. As we mentioned, we will be able to send you all the slides and a recording of today's event as well. But it's been a really inspiring event. And I just want to just follow up what Marie was saying about the rest of Australia is watching, because I'm coming to you from New South Wales, and we don't have anything like what we've been discussing all day today in New South Wales, even remotely on the agenda. So what you're doing in Victoria is not only is leading Australia in terms of mental health reform, and it's something that you should be really proud of, all the hard work that's gone into this so far, and that's going to continue. The lived experience model, listening to people, listening to carers, having that really collaborative approach, and then wrapping around people, meeting them where they are. And when Katherine Whetton was describing what it would be like, that system of just assessing someone, making sure they get the therapy, that their well-being is looked after, the peer support, team coordinated approach, it sounds like such a great model, and I really am looking forward to seeing how it all works out in the next weeks and months. And yeah, so look, thank you for being part of this really good day and last week as well. If you want to connect with me at all, the best place is probably on Instagram, because that's where I spend a fair bit of time talking about mental health. So you can see on the slide there, my name is Sophie Scott and the number 2. So please connect over there if you want to follow up anything we've talked about today, or you want to get in touch. But it's been a really, really great session, and thank you for asking me to be part. Thank you, Mental Health Victoria, for really being very forward thinking, and so putting all this hard work and effort into creating this symposium. We're going to be having more of these later in the year in November, and the best way is just to stay in touch through the Mental Health Victoria website, and make sure you're on their mailing list so that you can get details of all their other great events they've got coming up. But as I said, don't forget to do the evaluation before you jump off. But thanks so much for staying with us for the whole of these 2 days. It's been a really amazing event, and I'll see you next time. Bye now.